activities in the past 12 months. In the second part, we will be hearing from the four working groups of the I strategies. But to begin with, we are honored to have an opening address via video from Dr. Sid Berkeley, the CEO of Gavi, the Vaccine Alliance, one of our key partners. Over to you.
Thank you for inviting me to speak here today on the second day of the I annual meeting. It's such a pleasure to address the participants after yesterday's fruitful discussions. Gavi has been a committed partner in the I strategy since its inception, with the Gavi board approving up to $428 million for yellow fever vaccine during 2016 to 2020 and $424 million during the 21 to 25 period. Gavi funding has supported the introduction of yellow fever vaccines and the routine immunization schedules of 17 countries at risk of epidemics of the disease, in addition to mass preventive campaigns and maintaining a rolling emergency stockpile. Preventive yellow fever vaccination alone reached more than 187 million people up to 2020. Beyond vaccines, other investments include technical assistance, cash grants to support immunization delivery, and most recently, additional funds for yellow fever diagnostic procurement and laboratory capacity strengthening. This yellow fever diagnostics initiative was approved by the Gavi board in 2018 as an experiment with a view to leveraging expected surveillance efficiencies for effective and equitable yellow fever vaccine deployment. Specifically, $8.2 million were allocated to fund diagnostic equipment and supplies, and $5.3 million to strengthen lab capacity in up to 24 African countries for the 19 to 21 period. This marked a great milestone, not only for Gavi's yellow fever support, but for the collective efforts of the I strategy. These additional investments in diagnostic capacity across Africa have already borne fruit. 21 countries have received reagents and consumables for conducting first-line yellow fever serology tests, helping to prevent testing delays from stockouts, and a validated commercial yellow fever PCR testing kit is now available to help expand countries' testing capacity. The number of laboratories able to confirm at least some yellow fever samples has quadrupled in African countries at high risk for yellow fever epidemics, with the certification of labs in Nigeria, Cameroon, and Uganda. Overall, African countries at high risk of yellow fever epidemics that are eligible for new Gavi vaccine support have seen more than a 60% reduction in the amount of time needed to complete testing, from over 3.5 months in 2017 to 39 days in 2020. So despite the progress we have seen so far, millions of children are still being left behind. Every year, nearly 10 million children in Gavi-supported low-income countries don't receive even a single shot of a basic vaccine, with millions more receiving some but not the full complement of recommended vaccines. This leaves them vulnerable to some of the world's deadliest diseases, such as yellow fever. The low routine yellow fever immunization coverage across Gavi-supported countries is still a reason of concern. In the past few years, we've seen a slight increase, but the impact of the COVID-19 pandemic halted this trend, and in 2020 it fell to 53% coverage, well below where it needs to be. This devastating pandemic is a stark reminder of the importance of strong routine immunization systems and epidemic preparedness. It has disproportionately impacted already vulnerable populations, which means that more children are likely to miss out on basic vaccines. It's crucial that we focus our efforts on maintaining and restoring routine immunization. We also need to further strengthen our programs and increase routine coverage of epidemic-prone diseases such as yellow fever. This is the best way to avoid outbreaks in the long term and the need for costly supplementary immunization activities. Gavi's priority over the next 5 years will be getting vaccines to zero-dose children and their communities. In this process, we hope to build resilient systems to deliver additional primary health care services. However, the only way we can achieve these goals is by working together across governments, international agencies, and civil society so we can comprehensively serve missed communities and generate wider benefits beyond immunization. The I strategy is a noteworthy example of the benefits of multi-stakeholder collaboration. To obtain the goals that we have set for ourselves by 2026, we need to reinforce our efforts, further engage with regional and country partners, and focus on these missed communities. Gavi remains committed to the fight against yellow fever through the multiple avenues of this strategy, and we encourage all partners to build on the success we have seen so far. Thank you for your continued partnership, and I wish you the best in the upcoming discussions.
Thank you so much, Dr. Berkeley. You're always eloquent as always. We now move into the first session of the day, where we are delighted to have presentations from 4 priority countries within the I strategy. Raki will be putting a link into the chat for a country twinning survey. We really need your feedback on how a country twinning, or we can say knowledge exchange program, could look between countries and regions. It only takes a few minutes to fill it up, so please click on it and give your feedbacks. It will help to build a program that benefits everyone. We first go to Ghana, and after the presentation, I'll provide a brief update from Sudan, and then we will have a 15 minutes question and answer session. So please submit your questions in the Q&A function in Zoom or the Events app. For our first presentation, we have with us Dr. Kumar Mapong Aquino from the Ghana Ministry of Health. Over to you, Dr. Aquino. Once again, please submit your questions in the Q&A function in the app or on Zoom itself. Thank you.
Yeah, thank you very much, and good afternoon from Ghana. So my name is Kwame Amponsa Achiano. I know it's a mouthful, so you can simply call me Kwame, which is a bit easier. So I'm the manager for the of the immunization program in Ghana. I'll be presenting for the country. Next slide, please. So I'll follow a background, like the brief background to the yellow fever and its control in Ghana, the rationale for our campaign, few achievements and lessons learned, and then I'll draw a few conclusions. Next slide. Yes, so Ghana firmly lies within the yellow fever belt, as you can see on the right side. And not until quite recently, we continue to report cases almost every year. The cases previously had been in pairs with focal outbreaks in spite of the high routine immunization coverage and our initial selective mass campaigns that we started some years back. We did a risk assessment with support from WHO in 2010, and it was adjudged that Ghana, almost all districts were at risk of yellow fever. Next slide, please. Yeah, so these are the control measures that we've put in place over the past few years, and let's say many years. We started routine immunization in 1992 when yellow fever was introduced as part of the ongoing immunization program. We've also been doing preventive mass vaccination campaigns in order to rapidly increase population immunity and to protect susceptible older age groups. And of course, outbreak response has also been one of the key pillars in our control strategy. And we've carried it out during epidemics with minimum delay in order to limit the spread. And finally, and one of the most important pillars is yellow fever disease surveillance. So on the right side, you see a map of Ghana that shows where we've been reporting yellow fever outbreaks until quite recently. In fact, the whole period, country, especially the northern parts, used to report a lot of outbreaks until recently, when we have done quite a number of campaigns, which has limited the spread of the disease. Next slide, please. Yes, so by way of documented campaign strategies, we did selective mass vaccination campaigns. Normally, initially we used what we used to call the medical field units in Ghana, which was more or less a mobile team that did selective mass vaccination campaigns. Then we did a combination of that together with yours control somewhere in the early 80s. Then officially started the preventive mass vaccination campaigns in the mid-1980s. Then, as I did indicate, in 1992, yellow fever became part of the childhood immunization program. So these are the documented campaigns we've done over the past 20 years or so. We did a preventive mass campaign in 2005, 2007, 2011, 12, and lately 2018, and just last year, we completed our campaigns. So on the right side, we have data from 1950 that shows the explosive outbreaks we used to have prior to the immunization program, that's the childhood immunization program. So the right line shows coverage levels of the childhood immunization in terms of yellow fever, and the blue bars are those cases of yellow fever. So along the line, we did have some explosive outbreaks. And then, of course, you see the periods where we did selective mass campaigns and also the preventive mass campaigns. Next slide, please. Yes, so I mentioned the risk assessment that was carried out in 2010. All our districts, most of our districts conducted preventive mass campaigns because it was adjudged that the whole nation was at risk. So between 2005 and 2018, we did a number of preventive mass campaigns, but we left out some districts, about 86 of them, which remained at risk. And in line with the new global strategy of eliminating yellow fever epidemics, in order to protect at-risk groups, prevent international spread, and contain outbreaks rapidly, we needed to cover the left-out districts in terms of preventive mass campaigns. So we had to reach the unreached. Next slide, please. So within that context, within the context of the rationale for the campaign, we also had to struggle with the fact that our campaigns had been planned, but unfortunately, because of outbreaks in Angola and Democratic Republic of Congo around 2015, thereabout, we had to postpone the campaign. Again, as we all know, we're hit by the COVID pandemic, and it had both direct and indirect effect on service delivery. So we had to reassign key staff in EPI and many other public health controls programs to COVID-19 control duties, especially in terms of surveillance and response. Then we were also hit by the lockdown in major cities, which restricted movement across all the parts of the country. We had a near complete shutdown of public transport system when the lockdown occurred. There was also some fear and apprehension among health workers that affected supply of services. And then finally, the population itself were gripped with fear, especially during the early days of the pandemic. And therefore, even when the services were available, they were not patronizing. So this is one of the contexts within which we had to carry out this preventive mass campaign. At the time, we were also experiencing an outbreak of circulating vaccine-derived polio virus type 2, which we were responding to. Then, as I indicated, we had originally postponed our campaigns, and because of all these conditions, we postponed the campaigns on 2 occasions. Also, the decline in coverage of health interventions as a result of the context within which we found ourselves, including the pandemic. And of course, the last quarter of 2020 was mainly an electioneering campaign period. And so we in Ghana had our general elections, and normally around that time, there's a lot of apprehension and things are not very straightforward. So we had to do the final campaign within these conditions. Next slide, please. So these are some of the key lessons that we learned. That what were the enablers? We were successful in doing the campaign because of our experience and success stories of immunization in general. The Ministry of Health and Ghana Health Service by extension also took ownership of the campaign. We had a strong partnership, especially around the COVID pandemic, initial pandemic period. We had a lot of interactions with our partners, WHO, UNICEF, CDC, PATH, who supported us in planning for the campaign. We had regular teleconferences between the country as one, and then of course the I Secretariat, some of who actually came to support the campaign. We used different strategies to reach our target populations. And of course, the extensive use of social media, which has its pros and cons. But for us, the WhatsApp platforms helped us in sharing key information and on a timely basis on the campaign. And of course, we had to do a wider stakeholder engagement. So these were some of the enabling factors that helped us. But we were constrained by the fact that there were rumors that around COVID-19, people were around the COVID-19 pandemic declaration, people had a lot of fear and apprehension about vaccine trials. So there were rumors that government was using, was trying COVID-19 vaccines under the guise of yellow fever campaign. We also had low adherence to COVID-19 protocols, including the social physical distancing, hand hygiene, and face masking. And this largely affected was actually what the community members refused to do. We also had questions about the relevance of conducting a preventive mass campaign during the epidemic or during that pandemic. There were questions around that. And we needed to justify the fact that in spite of COVID, there were all the other diseases were occurring. And so we needed to protect our people. There was also the increase in costs in terms of personal protective equipment and sanitizers, which we needed. We're not used to having such protective equipment prior to the COVID. So we needed these and we needed to add on to the campaign costs. And of course, also the political activities that restricted us in a way. Next slide, please. So we developed a guidance document on the continuity of immunization services, including mass campaigns. This guided us. And we also included measures to reduce COVID-19 transmission during the immunization service delivery. So we had continuous orientation of healthcare workers and the general public. We identified hotspots for COVID transmission and used facility-based strategies only in those areas, whilst we did both outreach and static sessions in the other areas with minimal or low COVID-19 transmission. Then also we had trainings conducted in smaller groups. Where appropriate, we did some kind of virtual meetings, but we restricted them as much as possible. We conducted an intensified social mobilization using community radio stations and TVs, as well as national and local platforms. The population also appreciated the fact that there was a possibility of having a yellow fever outbreak, and therefore, with all these, within these confines, we were able to convince the population that we needed to embark on the campaign. Next slide, please. Yeah, so we've achieved some successes, administrative coverage, and then also the post-coverage survey data are presented here. The campaign was conducted from the 12th to 18th November, 2020. We targeted 5.7 million people. We reached nearly 5.3 million. And some persons had already been vaccinated in the districts that were left out. And we used evidence by card to document those who were already vaccinated. And so in total, we'd say that we protected 5.36 or nearly 5.4 million people in these selected districts. And therefore, proportion protected was around 94%. Now, when we juxtapose this with the post-campaign coverage survey, which was carried out between 11th and 15th December 2020, our target coverage was around 83%. So for those that were vaccinated by card only, it was around 67%. And then by recall, nearly 16%. So together, it's about 83%. The level of awareness was not as we would expect, but it was not too bad as well. It was almost 77%. A major reason for persons not getting vaccinated was the fact that they were absent during the campaign period or not aware of the campaign at all. Next slide. So we make a few recommendations to countries that probably will be planning. I'm sure by now, because of the experiences with COVID over the past few months, probably are better at it now. So government ownership is key. We also need to engage relevant stakeholders as early as possible. We have to have some guidelines for conducting vaccination sessions, especially within the context of COVID-19. We have to develop a communication strategy with risk mitigation plans so that we can use that to monitor rumors and use information to update the strategy. Also use a two-way communication process where possible. It shouldn't be a one-way thing. We would have to budget for PPEs and other key logistics, including hand sanitizers. We'd have to organize trainings in small groups. Our experience teaches us that the virtual meetings may be good, but for practical purposes, we would prefer that we would recommend that we do small trainings face-to-face or in-person trainings as much as possible, but of course with limited groups. And that we can use a virtual means for daily review meetings where possible. So this is what Ghana has for you. Thank you very much for listening. Over.
Thank you so much, Dr. Kwame Medasi. I hope that forgives me for my mispronunciation.
That's okay.
Thank you very much. Thank you. I already see some question answers coming in, but just let me give you a little recap of we did want Sudan to present. I'm sure all of us were looking forward to hearing from Sudan. But during the political situation, Dr. Hanan could not be with us today. But we still want to really recognize the country's great achievements, in including the yellow fever vaccination in their routine immunization, and they had that nationwide in July 2021. In addition, the country has been implementing catch-up yellow fever vaccination campaigns in 5 states to date and engaged in innovative outreach to vaccinate refugees. So thank you very much for all those who tried to get Sudan in, but unfortunately we couldn't. I would like to take this opportunity to put some questions up. We have with us Mr. Pedro, who wants to know, how was the evolution of yellow fever cases during the COVID-19 pandemic?
So good afternoon, everyone. This is Jen Horton with the I Secretariat, and maybe I'll just jump in and then colleagues may wish to complement. I think the answer is a little bit complicated, but maybe in brief, what we saw in 2020 was that there were numerous yellow fever outbreaks in a wide geographic distribution. So while we are aware that there was an overall decrease in the number of suspect cases reported, the subset of cases that were notified were representing indications of intense yellow fever transmission with outbreaks in a fairly broad spectrum. So in brief, there were outbreaks in East Africa, in Uganda and Ethiopia in the early part of the year. And then subsequently, there were outbreaks in several parts of Western Africa, including multiple resurgences of outbreaks in Nigeria. And I believe we'll be hearing more about that later today. And then there were also outbreaks in Senegal and Guinea. So overall, there was quite intense yellow fever transmission last year. Over.
So Priyanka, back to you.
I'm sorry, there was some issue, technical glitch. Thank you very much. We have actually some more questions coming in, and we wanted to really know, now that the campaigns are completed, are there other priorities for the yellow fever control activities planned? For example, surveillance or enhanced routine immunization in high needs areas? Anything else? Over to you, please, Jennifer.
Priyanka, could you repeat your question for Jennifer? Over.
Certainly. Now that the yellow fever campaigns are over, especially in the countries we talked about, can you tell us what is the other next priorities? Are we talking about increased surveillance, enhanced routine immunization in high need areas, others? Over.
Thanks very much, Priyanka. So indeed, there are numerous additional priorities through the I strategy. So the strategic objectives are actually quite broad, and so additional priorities that we'll be hearing about in the coming days will include a close-up on some of the developments in risk analysis for yellow fever. And embedded in that, of course, is the importance of strengthening surveillance. In addition, we'll be hearing more about urban preparedness in tomorrow's sessions. These are just a few of the upcoming priorities for the strategy that will be discussed in these sessions. Over.
Thank you so much, Jennifer. We also have another question, and I hope we can indulge us, or we can also pass it on. We wanted to know, this message is for Ghana. Congratulations on the success of completing the nationwide campaigns. Given that the final phase was completed with many competing priorities, including elections, COVID-19 pandemic, could you discuss a bit more on what you were perceived as the greatest unexpected challenge and how Ghana overcame these? Dr. Kwame?
Obviously, the greatest perceived challenge was the fact that we had a pandemic, an unprecedented pandemic. That brought a lot of fear into people. There were people, the health workers were afraid from the beginning, and the community itself was also afraid. So as I said, when services were even made available, people did not come for it because they were afraid they were going to be infected. Over time, we tried to heighten our awareness and especially engagement of communities. Initially, there were even some health workers who were literally chased out of their communities, not necessarily during the campaigns, but for routine immunization and other public health activities. But over time, we gradually came over it and also had to convince high-level management that we needed to complete this campaign in order that we don't get caught by unexpected outbreaks within, an outbreak within an outbreak. In other words, yellow fever outbreak or say measles outbreak within the COVID pandemic. So we needed to really work hard at it. We had a lot of stakeholder engagements, and that is when we came out with plans, guidance for public health persons on how to, the continuity of service in terms of routine and other. We did this together with other programs, including maternal and child health, and malaria, and many other programs. Then also we needed to reassure the health workers that they were going to be protected. So initially we struggled to get the PPEs and also to be able to document, get a home-based record for each vaccinee. We needed to convince high-level management. Unfortunately, it was not part of the budget, and we almost nearly canceled the campaign again because we're not having seen any clear way forward. So thanks to CDC Foundation, within 2 weeks or so to the campaign, they came to our aid to support us. And so that built confidence in terms of the PPEs, the hand sanitizers, and then of course the home-based records that we needed to give to vaccinees. And so that is the, I would say that our greatest challenge during that time. Over.
Thank you, Dr. Kwame, and we are really impressed by the work you've done. Please don't leave us. We have another question for you. Can you please describe a little bit more about the innovations to mobilize communities and counter misinformation? I know you talked about using other campaigns, but if you can elaborate a little bit more on this, thank you.
So again, as I said, normally before any campaign is done, we have an overall committee or technical working group, and within that we have subcommittees. So we have a very vibrant communication subcommittee with support from all partners, WHO, UNICEF, the traditional partners, and extended partners, PATH, ESI. We also had USAID and many other partners supporting. And so we came up with a communication plan. And normally before a campaign, we start with the social mobilization and communication activities during campaign and even immediately after the campaign. So within the plan, we teased out our key messages and started airing before the campaign started. As the campaign went on and we realized that we needed to change the strategy, we moved some static teams turned out to be more or less a mobile team. So getting to the end of the campaign, we actually sent the vaccines to the doorstep. So literally turning it into a kind of a house to house, but with a modification. So we did more of a modified mobile campaign. And then before then, you would have volunteers, including Red Cross volunteers who supported us with house to house engagement before the teams got there. So that is how we're able to manage this campaign in terms of social mobilization and communication. Over.
Thank you, Dr. Kwame. And was the recent yellow fever vaccination campaign experience useful to inform the rollout of the COVID-19 vaccination? We want to know if there was a flow of lessons learned both ways. Thank you.
Yes, definitely yes. And that is what we've even been using in our success in COVID-19, even though we still have some challenges with uptake of the vaccines. But because of our experience with yellow fever, which essentially is for adults, and of course the COVID-19 vaccination is also for adults, we picked lessons from the last campaign we did in 2020 to shape the COVID-19 vaccination. So we are still employing similar methods of community engagement, engaging on social media, and of course local FM stations as well, including the TVs. And then as and when we have to change the strategy, this time is very district specific. So depending on the district consent, they do a modified mobile. We're actually using all kinds of strategies, static, camp out, where we move into the islands and stay there for some time. We also do our routine outreaches, a combination of them, and then of course a modified mobile. And we would say that the yellow fever campaign, the last one we did within the context of a COVID-19 epidemic, has really shaped our delivery or deployment of the COVID-19 vaccines. Over.
Thank you so much, Doctor. We also have some more questions in our Q&A, and this is Yusuf Asrat. He's asking, did the I strategy have a plan to support financially the yellow fever case-based surveillance in Afro? Thank you. I believe, Jennifer, would you be in the position to answer this? I repeat, this is a question from our Q&A chat. Did the I strategy have a plan to support financially the yellow fever case-based surveillance in Afro?
Thanks very much, Priyanka. I think Actually, this would probably be best answered by our Afro colleagues, but just briefly at the global level, we are indeed very interested in supporting initiatives in terms of surveillance and laboratory data strengthening at our level. And I believe that perhaps one of our regional colleagues wishes to complement on activities at their level. Thanks, Silver.
Thank you, Jennifer. Would somebody from Afro be able to address this question? Thank you.
Priyanka, this is Maurice.
Please go ahead. Thank you.
Yes, thank you. As the director of Gavi said, for now, the support from Gavi concern mainly the laboratory diagnostic. Maybe in the next year we might involve the surveillance, the case-based surveillance. But for now, the support concern only laboratory diagnostic and capacity strengthening. Over.
And Priyanka, if I may, just also, I realized I should mention also that many countries actually are implementing case-based surveillance for yellow fever already. And so I just want to be clear that we recognize that, and really a thanks to all those countries that have implemented case-based surveillance. It is the recommendation through the 2020 vaccine preventable disease surveillance standard for yellow fever. And so we are certainly encouraging and supporting further rollout of that where possible too. Thanks.
Thank you so much. We also have a question from Jorge Gomez. He's asking.
Priyanka, we have a hand
Yes.
raised from our other focal person in Afro, Blaise Batondole. Over.
Sure.
Yes, this is Blaise. Can you hear me, please?
Yes, we can. Thank you.
Okay, thank you. I just want to add on what my colleagues have just said. Actually, out of the 27 high-risk country in Afro, almost 20 are implementing case-based surveillance. And we are still having 7 countries which yet to introduce case-based surveillance. And if you could see during the Afro presentations yesterday, this is one of the priority we have in the next time, where we are going to support all these countries with capacity building, and then go ahead with the implementation of case-based surveillance in all those countries. We have this plan, maybe in coming weeks, we are going to launch it in those countries who have not yet introduced case-based surveillance in their surveillance program. So it is part of the Afro priority, and we are moving forward on implementation. Over.
Thank you so much. Please don't leave us. We also have a question from Jorge Gomez. Are these vaccinated registered with an identity card in a database? What are the impact of vaccination campaigns on mortality and lethality? How much did they decrease? And also a related question is how vaccination of local migrants was carried out. Over.
Sorry, who's the best person to take that question? Blaise, is that something you're able to answer?
Okay, thank you very much, Raki, and thank you for the question. Maybe I can respond to the second part of the question.
Thank you.
Exactly. As per our plan in next month, next week, and as you saw it yesterday, we have also given priority in vaccinating vulnerable population. It is only local migrants it is also some of all those migrants and other people working in companies like mining companies, those who are exposed to sylvatic transmission. And we realized that there is no plan for vulnerable population vaccination in countries. So we are going to work on this. It is one of our priority that we are going to implement in those countries so that we can use all those companies also to have a plan and a policy of vaccination of all the vulnerable populations, including migrants. Over to you.
Thank you very much. And thank you, Dr. Kwame. Thank you, Dr. Jane, Dr. Belaise, Dr. Moraes. Thank you very much for your questions and for your answers. If we do not have anything new, I'm checking the Q&A again. Yes, we do have another question. In Ghana, what was the place of communication digital in the awareness of people and to mitigate risk? Have you used it? And what was the involvement from the social network actors during the campaign? I believe if
Yes,
Dr. Kwame is still with us.
Yes, thank you. Yes, I'm still here. Thank you very much. Yes, so as I did indicate, our the communication subcommittee draws from a very wide range of stakeholders. That includes the civil society organizations. We have a very vibrant non-governmental organization group in Ghana, and they are always represented. So they support with the social mobilization activities, especially at the community level. In fact, they're almost everywhere. And in all the districts that we did a campaign, they are there as well. So they supported us. Apart from the strategy, drawing from the strategy, we also use civil society and especially the media. We have the media as part of our team. And so during the planning stage and execution stage, we involve them as well. So that's how come we are successful. The media in Ghana is very vibrant, and constant engagement with them is very, very, very useful in such endeavors. Over.
Thank you, Madasi again. Thank you. We would like to move on to our next country presentation. And once again, thank you very much for your engagement. We have our next two country presentations now, and honored to have another representative from the Ministry of Health of the Democratic Republic of Congo. For those of you that are here yesterday, you would have seen the short documentary films on the yellow fever vaccination campaign earlier this year. If you've seen the film, you will recognize our next speaker, Dr. Elizabeth Mukuba. I believe Raki is putting the link for the two films, one long, one short, into the chat, and maybe we can see it later if we were not here yesterday. As always, please submit your questions in Q&A function in the app or Zoom, and we are likely to have this presentation in French, so we request you to choose your preferred language. Thank you.
Dr. Elizabeth, vous êtes là? Does anyone know if Dr. Elizabeth is online? I think we may
I don't
have...
think she's connected to the call, Raki.
Okay, maybe there might be an issue. I wonder if Dr. Turner is available and we can maybe move to the Nigeria presentation. Dr. Turner, are you there? And we can come back to DRC.
Yes, I am. You can go ahead.
Thank you, Dr. Turner. So just give us 1 second to put your slides up, and then thank you for stepping in.
And thank you, Raki, for troubleshooting.
No problem.
We are hoping that we do get Dr. Elizabeth later, but thank you so much, Dr. Tarna, Nawage from WHO Nigeria Country Office, who will be presenting the last 12 months in eye strategy's highest risk country. As always, please submit your questions in the Q&A function in the app or on Zoom itself. Thank you.
So thank you very much. It's a pleasure to speak on behalf of the team here in Nigeria. Like we know, for us in Nigeria, the eye strategy is implemented through basically the Nigeria Centers for Disease Control, where we had heard Dr. Chikwe Ekwazu speak about some of his experiences yesterday. Also the Nigeria Primary Healthcare Development Agency, which is responsible for immunization, as well as the Port Health Services from the Federal Ministry of Health. Next slide. So we will just speak through a bit of a retrospection of last year, some of the things that had happened within the eye strategy implementation. We will have some conversations around COVID challenges, as well as what we had learned from that. We'll also share with you our experiences in integrating vaccination campaigns in Nigeria, and as well some of the lessons that we had heard from the recent regional meeting and the context of polio transition happening in Nigeria at the moment. Next, please.
Dr. Turner, could you put your video on, please? We would really love to see you while you're presenting. If you don't have connection issues, it would be great to see you.
Okay, that's fine. That's the best that I can do right now.
Okay, thanks.
Yeah. Just starting up with where we are for the yellow fever routine introduction in Nigeria happened in 2004. We're sharing, we can see on this slide where the trends over the last couple of years. I think the message here clearly is that since the introduction in 2004, we haven't been able to achieve an optimal coverage. And in the last 3 or 4 years, the projected the coverages by WINIC estimates have stalled around 54%. Again, this is also interesting, comparing also the MCV1 estimated coverage across this period. So we still have huge immunity gaps across the country, and also a lot of work that has to happen around routine immunization. Next slide. So what has happened in the last couple of years between 2018, when the eye strategy was launched in Nigeria by the Director General of WHO, and the big pandemic of COVID? What are the changes that have happened in Nigeria since then? We will see that in 2017, the first set of map you see there, we had the outbreak that had been alluded to yesterday by the NCDC DG in Ifelodun in Kwara State, where we were able to, through the support of the ICG, respond via a reactive vaccination campaign. Same year also, we were also able to respond to outbreaks also that happened in the same Kwara and Kogi state, as well as in Zamfara state, somewhere up north. And the link between those two outbreaks basically were movements of gold miners across the states, and that was how the outbreaks spread. In 2018, again, we also had the same outbreaks in Kebbi, all linked to the previous year's outbreak. And then in later part of 2018, we also had responses conducted in Borno as well, in the far northeast, moving forward. By 2019, we had conducted preventive mass vaccination campaign across almost 13 states, based on the phased approach for the vaccination, the eye strategy, which had been adopted by the country. And the approach was to have because of the huge population size as well as the global availability of vaccines to ensure that we cover the whole country within a period of 2017 up until 2023. Also to add up, like I said, in terms of the context of COVID, we had also seen in routine immunization a huge decline in the number of children who had routinely received their vaccination, their yellow fever vaccination on a month-to-month basis. From the January, where we had almost 80% of the targeted persons reached, to the end of the year, where that number had dropped up until somewhere around 34%. But in total, cumulatively for the year, the reports for yellow fever control had reduced drastically, with almost 4.8 million of the targeted persons not reached during this period. Next slide. Now, this is just a summary of the vaccination campaigns that have happened in the country over the past few years. Prior to the I strategy, there was an initiation of yellow fever campaigns through the Yellow Fever Initiative in 2013 and 2014 across 3 states, with almost 10 million persons vaccinated with the yellow fever vaccine. But there was an interruption of the planned campaigns due to issues around global shortages, which clearly were linked to the big outbreaks that happened in Angola. And so following the I strategy launch, the campaigns commenced again. We had 3.3 million or so persons vaccinated via reactive vaccination. We also had 26 million persons vaccinated through preventive mass vaccinations in 2018, and another 5 million vaccinated through reactive campaigns. In 2019, we were able to vaccinate almost 21 million persons through preventive mass vaccination campaigns, as well as 4 million persons through reactive campaigns. Just to make a comment here, that the planned campaigns for 2019 were a whole lot bigger than this. These numbers were the numbers that we were able to achieve by February, March, before the huge impact of COVID. And so by March of that year, all the planned campaigns for 2019 had been delayed or postponed, and then rolled over up until 2020. And in 2020, we were able to vaccinate somewhere around 30 million persons through planned vaccination campaigns. You will see that those 20 million persons were vaccinated in the context of COVID, and we will make some comments around that slightly later. By the end of 2020, we had a big outbreak in some of the states in Enugu, as well as Delta State. And we also conducted a reactive vaccination campaign in 11 LGs, where we had 2.5 million persons aged 9 months to 44 years vaccinated with the yellow fever vaccine. Next slide. So in total, you will see that over this period, we've been able to vaccinate somewhere around 103 million Nigerians with yellow fever between 2013, when the initial campaign started, till 2021. 88 million of these were vaccinated through preventive mass vaccinations, and 15 million of these through reactive vaccinations from support that we had gotten from the ICG. In total, we had submitted almost 13 ICG requests during this period. 11 of them had been approved, and we were able to implement across these LGs to have the 50 million persons vaccinated. What was also interesting around these vaccinations also was adapting to the prevailing situation. So for instance, in 2020, when we had the outbreaks, even though we had planned preventive campaigns ongoing, we had to sort of initiate the preventive campaigns earlier than planned, enabled to address the outbreaks that had happened in Delta State. And we were able to, we were glad that that outbreak we were able to interrupt quite well. So following this campaign that happened, we had delays for the 2021 campaigns. The planned campaigns for 2021 cover 5 states, currently targeting about 17 million Nigerians. These campaigns are expected to commence in Nigeria in the next couple of weeks, and we're hopeful to have this cohort of Nigerians vaccinated. So in total, by the end of the year, we expect to have vaccinated somewhere around 120 million Nigerians, and hopefully we'll have another 50 million Nigerians, which we're hopeful to vaccinate in the next 2 to 3 years, based on vaccine availability and allotment to the country based on global supply. Next slide. So just a few comments around COVID and the pandemic. We had shared some of the impact we had already seen with routine immunization. But like you know, most of the campaigns that were delayed or interrupted due to COVID meant that we needed to sit down and review all the protocols that were required for mass vaccinations. Working with guidelines that had come up from the global and the regional team, we also adapted our SOPs for implementing both polio and non-polio SIAs in Nigeria in the context of COVID. And based on this, we had clear guidelines of what were the expectations and how these campaigns were supposed to happen. To also add up onto this and ensuring that teams and guidelines were implemented, if you can click one bit, please, Priyanka. Just one click on the slide, please.
Yes, yes, sure.
So we also had some clear points which we were tracking. It was important for us also to ensure that teams were not only having face masks available, but were wearing the face masks properly. We also, as part of our guidelines, needed to monitor and ensure that the teams actually had either hand sanitizers or access to water or liquid soap to ensure hand hygiene at the post. And also, we also, even though there were government guidelines around the use of face masks in public, our guidelines also said, even though we couldn't enforce that, but also to be sure that persons had some kind of face covering when they came to the post for vaccination. And most importantly, we also wanted to be sure that the health workers themselves, because there was a lot of anxiety at that time, we wanted to be sure the health workers themselves were quite comfortable that they were being protected from either being exposed as well as also transmitting COVID to the persons that they were taking care of. So we also, as part of the protocols, we had recommended that for any member of the team who was ill at any point in time, needed to be dropped from the team immediately and referred for testings to any of the sites that was managing COVID cases. So as part of this process, we had all of this included as a supervisory checklist where monitors assess these. And then you will see that most of the indicators, the teams, we had almost 96% of the teams wearing face masks. We also had water and sanitizers in almost 99% of the vaccination sites, 92% having access to water and hygiene. Only 64% of the community members who were coming to the vaccination post had some kind of face covering. And we also had 37% of the health workers who felt that they were appropriately protected against COVID at that time. So these were some of the measures that we put in place. And even as part of the post-campaign coverage survey questionnaire, these also were continuously monitored, and we reported on this as part of the process and lessons learned moving forward. Next slide. I think it's also important to put all of this in context for all the immunization activities currently going on. We know that there's a huge COVID vaccination rollout happening in Nigeria, targeting almost over 100 million persons. We also know that multiple outbreaks are still ongoing. We've been responding to measles outbreaks in Borno, also cholera vaccination responses in Bauchi, Jigawa and Yobe State, as well as Zamfara. And in all of this, we have planned yellow fever campaigns in 7 states and a mini Men-A catch-up campaign in 12 states. This is quite critical because it shows all the activities that are happening around immunization, and then that delicate balance which we have to strike between routine immunization services as well as supplemental immunization services, ensuring that we do not have a disruption in this balance. What is key here is that all of these activities I have described here today clearly are still being implemented, and the services provided by the same health worker, relying on the same cold chain system and coordinated at the operational level by the same local immunization officer. So if you'll ask me, the local immunization officers have had their hands full all through the year. And for many of us, we feel that they are really champions and have gone over and beyond to ensure that we're able to implement these campaigns. So on the next slide, like we said, we continue to implement integrated campaigns for this year. 13 states have been targeted for implementation. We will be having in some states standalone measles campaigns, about 4 or 5 states of that. In another 3 or so states, we'll be integrating measles and Men-A campaigns. And also in a few, we'll be integrating measles campaigns with yellow fever campaigns. So these plans have been clearly marked out based on the experiences that we had from last year in terms of integration. So the integration is not only at the point of delivery, but also in pre-implementation activities. So in terms of the micro-planning process, all of this is done at one. We also have the trainings that are coordinated as one to ensure that the information goes out clearly across board. We also have a very clear vaccination post layout. This layout for us is quite critical because it ensures that at every vaccination post, you have a health worker who is providing a specific antigen. And that way we don't have situations where people get vaccines that they are not eligible for or targeted for. And at the same time, all of this being done, trying to adhere to COVID protocols. Most importantly as well, in terms of documentation, we continue to provide vaccination cards to document all the vaccines that have been given at each post. And for this campaign also, we also will be implementing where for every child that gets vaccinated, all the antigens that are provided to that child are all documented on one card. So this is where we are with the integration. And we hope that we will improve on this as we move on to some of the other campaigns for 2022. Next slide. Next. So some of the things we had mentioned previously around, please back up one slide, please. Some of the things that we wanted to put on the fore in terms of the engagements from the previous Afro meeting, the issues and challenges around investigation of yellow fever alerts, as well as a laboratory confirmation, and the need for final classification based on detailed information regarding epidemiology and the vaccination status. This is one key thing which we are working towards, and ensuring that investigations are timely and the information needed for the final classification are available when needed. The other thing to highlight also, because this is also something we had seen, was where we were having breakthrough transmission of yellow fever cases or confirmation in areas where we had already had yellow fever preventive mass campaigns conducted. So a clear guidance as to how that response should happen. We had one or two experiences where in breakthrough states, we were able to ensure and work with states to improve on routine vaccination of an expanded age group and those kind of things. So clear guidances around this, I think, are quite helpful for us as we move forward. The integrated approach to mass vaccinations, we have talked about that. And also the issues around responding to confirmations where you've had multiple results or confirmations of yellow fever and other arboviral infections. We're glad that with the presentations yesterday around arboviruses, and it's clear that further guidance as to how to approach this will be needed. The issues around delay in sample shipments and confirmation had been discussed yesterday, and this is something that we're also looking at improving as we move forward in the country. On the next slide, we'll just also talk about a few issues around polio transition, and this is quite critical because we know that within the eye strategy activities, lots of issues have also built around the polio program. Within the country context, these activities are coordinated by Accelerated Disease Control Team with funding from the polio or PEP cluster. Also, in terms of the preventive mass vaccination campaigns, fundings are directed through a direct implementation approach where payments are made directly to beneficiaries at all levels. And most of this is coordinated by administrative assistants or personnel across all the 36+1 states, usually funded through the polio program. Across the program as well, we also know that we have a stretch of personnel from cluster consultants to LGA facilitators of field volunteers who are out there in the field and supporting pre-implementation activities, including supporting micro-planning, trainings, as well as supervision. We have noticed with the polio transition, a reduction in some of these numbers and some of the challenges that may come up as a result of that. And most importantly as well, the polio data team that has continued to support data management for PMVCs. One to speak to around this will be the massive capacities and institutional memory of the personnel from the program who have played key role in the successful implementation of mass campaigns in Nigeria. I think there have been some engagement at country level with the PMG of the Eye Secretariat around some of the gaps that are made available from this and possible support from the Secretariat to try and bridge these gaps as we implement these mass campaigns, as well as all the other strategic objectives of the eye strategy. Next slide. So in conclusion, just to state, Nigeria has made quite some progress in the implementation of the eye strategy, particularly around preventive mass campaigns, with almost 103 million persons currently vaccinated and another 17 or so targeted for the end of the year. The impact of COVID has been quite huge, even though we are seeing some improvements in that, but we've lost out on quite some of the progress that had been made across the routine immunization over the last year. Despite the challenges with COVID, we have continued with mass vaccination, adhering to guidelines around mass vaccination, as well as adapting to the same context of multiple other vaccinations ongoing. More efforts are needed around improving the timeliness and completeness of the outbreak investigations, as well as ensuring that final classifications are done timely based on EPID and epidemiological information and other information from the detailed investigation. The current approach of integrated campaigns, which we have adopted in the country, is really the only way around for us to be able to conduct this campaign in a very crowded immunization ecosystem with multiple outbreaks, as well as the COVID vaccination still going on. We clearly acknowledge the support that the polio program has provided in terms of implementing activities around the eye strategy. And also we're quite cognizant of some of the gaps that this may provide in terms of implementing some of the planned activities moving forward. We know that with the initiation of conversation with the Secretariat by the country office, we're quite hopeful that some of these gaps will be bridged through the Secretariat. And hopefully, Nigeria hopes to accelerate its eye plan, and we will continue to engage with the Secretariat to ensure that vaccines that are made available to the country are utilized as best as possible to protect all Nigerians, and also ensure that we're able to eliminate epidemics in the country. Thank you very much.
Thank you so much, Dr. Terna Nowa-Mege. Please do stay with us. I can already see questions coming up for you, but in the interest of time, I request that we can do country presentations first and then go to Q&A. So please keep typing in your Q&As. Do let us know which country specific it is, so we know whom to address it to. But in the meantime, we are very happy to know that though Dr. Elizabeth Mukawa could not join us, we have Dr. Nicole Lubanda from the Ministry of Health of the Democratic Republic of the Congo joining us. And I believe that we have a presentation. I would just request the panelists to be a little more cautious of the time. I know it's something that you're doing all of a sudden, but please do be conscious of the time. Thank you.
Oui, bonjour à tous. Merci pour la mise en œuvre des activités préventives contre la fièvre jaune en République démocratique du Congo. Slide suivante. Nous allons aborder notre présentation sur 4 axes. Nous parlerons de notre contexte, une rétrospective de l'année 2020 ainsi que de l'impact COVID-19 sur la vaccination de routine, la mise en œuvre de la campagne préventive contre la fièvre jaune ainsi que des perspectives. Slide suivante. Du contexte de la République démocratique du Congo, nous disons que la RDC demeure un pays à risque d'épidémie de fièvre jaune suite à son écosystème favorable à la prolifération des moustiques du genre Aedes. Slide suivante, s'il vous plaît. Et qu'en 2017, nous avons adhéré à la stratégie AI et le pays s'est engagé à éliminer l'occurrence des épidémies de fièvre jaune d'ici 2026. C'est ainsi que nous avions élaboré un plan de travail planifiant une série de campagnes de vaccination préventive contre la fièvre jaune pour la période de 2020 à 2024 en 6 blocs de province. Et le besoin attendu pour le pays pour ces campagnes s'élève à 109 707 552 doses de VAA. Slide suivante. Alors, avec l'avènement de la COVID-19, le premier cas qui a été déclaré le 11 mars 2020, il y a eu un impact sur la vaccination de routine en termes de diminution du nombre de séances de vaccination, surtout dans la ville-province de Kinshasa. Il y a eu une demande de vaccination selon une enquête qui avait été organisée en 2020 qui faisait état de 23% d'abandon suite aux rumeurs d'une éventuelle vaccination contre la COVID-19. Il y a eu également la réduction de la fréquence d'approvisionnement des provinces en vaccins et autres intrants. du fait que 80% des expéditions des approvisionnements des vaccins en RDC se font par voie aérienne. Il y a eu également des résistances et refus à la vaccination, aussi bien de routine que de masse, suite aux rumeurs sur l'utilisation d'un supposé vaccin contre la COVID-19 en lieu et place de tout antigène qui avait été annoncé, qu'il s'agissait de la rougeole ou la fièvre jaune ou du MOPV. Slide suivante.
Dr. Nicole, si vous n'avez pas de problème avec votre connexion, est-ce qu'on peut vous voir? Votre vidéo?
Vous me suivez?
Si vous pouvez mettre votre vidéo.
Alors, nous disons que par rapport à l'organisation de la campagne de vaccination préventive contre la fièvre jaune en 2000,
Rocky and Priyanka, I think Dr. Nicole is facing some connection issues. So
Okay, yeah.
I don't know if John from the country office would be available to present on her behalf. If not, we might have to skip. John Otomba, would you be available to serve as a backup to Dr. Nicole? Over.
Yes. Oui, je peux prendre le relais s'il y a des problèmes de connexion.
D'accord, merci beaucoup, John. So Priyanka, John Samuel Otomba would be available to present on behalf of Dr. Nicole till she reconnects. Over.
Donc,
Mercy, thank you.
je peux continuer,
Sorry,
s'il vous plaît?
Dr. Nicole appears to be back on the call. Over.
Ah, OK.
vous m'entendez?
Oui, à vous.
Sorry, il y a un sérieux problème de connexion. Je disais qu'il y a eu des rumeurs qui sont survenues face à cette pandémie à COVID-19, mais grâce aux directives nationales qui ont été édictées par le ministère de la Santé, maintenant les services de vaccination dans ce contexte de COVID-19, nous avons pu maintenir l'offre des services dans toutes les zones de santé. Nous avons pu organiser des activités de vaccination supplémentaires ainsi que des ripostes aux épidémies telles que la rougeole, les CVD-PV, et nous avons pu organiser la campagne fièvre jaune dans les provinces du bloc 1, bloc 2. Nous avons eu des vaccinations réactives contre le choléra, la méningite et la 13e épidémie d'Ebola. Et toutes ces activités ont été menées dans le strict respect des mesures barrières qui ont été dictées par le gouvernement. De la mise en œuvre des campagnes en 2021, slide suivante, s'il vous plaît. Il était planifié en date du 27 avril 2021 le lancement officiel de la campagne de vaccination préventive contre la fièvre jaune dans 7 provinces du bloc 1 et la mise en œuvre est intervenue pour la même période du 27 du 27 avril et nous attendions vacciner près de 16 millions d'habitants. Slide suivante, s'il vous plaît. Y compris 296 000 réfugiés situés dans les provinces du Bas-Uélé, Haut-Uélé, Nord et Sud Ubangi. Dès la vaccination effective, nous avons pu vacciner 15 millions de personnes. Slide suivante. nous avons pu vacciner 15 millions de personnes sur les 16 millions attendus. Et des 7 provinces, seule la province du Haut-Uélé n'avait pas atteint l'objectif de couverture de 95%. Cependant, on a noté quelques zones de santé qui n'avaient pas atteint le dit objectif et se situaient dans toutes les zones de santé dans le record de 9 zones de santé dans la province du Haut-Uélé n'ont pas atteint cet objectif. Et de la surveillance des maladies évitables par la vaccination ainsi que des MAPI. Slide suivante, nous signalons qu'il a été rapporté des cas suspects de rougeole, de fièvre jaune, des cas de tétanos. Et s'agissant des MAPI, nous avons enregistré 8212 cas de MAPI moins graves, dont l'essentiel des signes étaient faits de fièvre, des céphalées, des douleurs au point d'injection, des vomissements. Mais en rapport avec les MAPI graves, 7 seulement ont fait l'objet d'une classification et 6 ont été liés à une réaction vaccinale. Et des efforts doivent être consentis pour cette investigation et classification des restes des cas. Slide suivante. Et à l'issue de cette campagne, il y a eu le monitorage indépendant qui a été organisé et a fait état de plus de 9% d'enfants non vaccinés pour la province de la Chopo, mais avec une moyenne de 4% au niveau pays. Et des principales raisons de non-vaccination, il y avait les absences. Slide suivante. Et nous avions en tête d'affiche, c'était les refus, suivi des absences, mais des principales causes de refus, nous avions enregistré la peur du vaccin à 52% et des personnes qui se disaient malades à raison de 14%. Il y a eu également des LQAS qui ont été organisés et nous avons enregistré, slide suivante, près de 29% des zones de santé qui ont vu leur couverture vaccinale être rejetée et dont la plus grande proportion a été enregistrée dans la province de la Chopo, qui était un peu comme notre province pilote, où vraiment nous avions enregistré énormément de refus quant à cette vaccination. Slide suivante. Et une enquête de couverture a été organisée et parmi des proportions des personnes qui ont été vaccinées par province, nous avions enregistré une bonne couverture quant aux enquêtes. Pour nous, nous jugeons ces résultats satisfaisants du fait d'énormes défis qui ont été relevés du point de vue communicationnel. Il fallait faire face à cette rumeur de vaccination éventuelle contre la COVID-19 et il y a eu des actions dans le cadre de la sensibilisation de communauté pour améliorer le niveau d'information et parvenir à l'adhésion à la vaccination. Slide suivante. Et des principales raisons de non-vaccination à l'issue de l'enquête, c'était des mauvaises idées sur la contre-indication et la plupart des personnes pensaient qu'ils n'étaient pas concernés du fait que c'est un vaccin qui s'administre en routine. Ils ne voyaient pas l'importance de se faire vacciner, mais également cette rumeur due à la vaccination contre la COVID-19 qui avait un peu été à la base d'une petite réticence, mais déjà au 3e, 4e jour de vaccination, nous avons pu obtenir l'adhésion massive de la communauté. Slide suivante. Et des facteurs de succès, nous signalons ce renforcement du niveau de suivi des préparatifs grâce à des outils digitalisés, de la même que la supervision et l'évaluation. Nous avons également la mise en place, slide suivante, d'une coordination appuyée par la stratégie nous avions tenu des réunions hebdomadaires qui ont permis de booster, d'orienter le pays quant aux préparatifs ainsi qu'à la mise en œuvre d'une campagne de qualité. Il y a eu ces déploiements des assistances techniques tant nationales qu'internationales avec nos partenaires OMS, UNICEF, PAC, qui ont appuyé conséquemment la coordination, la technique, la communication et la logistique. Il y a eu la mise en place d'un poste de commandement à différents niveaux, national, provincial et dans les zones de santé qui ont permis de booster les préparatifs et trouver des solutions locales à tous les problèmes qui ont pu survenir au cours de la campagne. Mais également cet alignement de tous les partenaires autour du ministère nous a permis, grâce à Stratégie AI, de mobiliser près de 300 000 doses et des coûts opérationnels pour la prise en charge des réfugiés qui n'étaient pas initialement pris en compte dans notre planification. Slide suivante. Et nous avons également des défis, c'est le non-respect. Il y a eu des problèmes rencontrés en termes de résistance, des multiples reports suite à la logistique, au financement qui était tardif. Il y avait une faible remontée des données suite à une faible connexion Internet et réseaux de communication. Cependant, il y a eu également des données de couverture qui étaient un peu divergentes de celles de gestion, mais nous avons pu résoudre les problèmes et arriver à une analyse des données en temps réel grâce à la synergie des efforts conjugués par tous les niveaux. Slide suivante. Slide suivante, s'il vous plaît. Alors, des leçons apprises, c'est ce contrôle de carte au point d'entrée qui a permis la vaccination des populations. Il y a eu des équipes mobiles qui ont été mises en place pour pouvoir atteindre les populations dans les milieux de concentration. Il y a eu la vaccination jusqu'à des heures tardives pour pouvoir récupérer le plus des populations possible. Slide suivante. La suivante, s'il vous plaît. La suivante. Alors, des perspectives, nous poursuivons avec la vaccination dans la province de l'Équateur et nous avons planifié la campagne dans le nord Kivu et l'Ituri pour la période de janvier à février 2020 et nous nous proposons de reconfigurer les blocs des provinces sur base des attributions du vaccin anti-amarine et bien sûr de l'approche géographique pour pouvoir contenir tous ces mouvements de population et si possible orienter notre vaccination jusqu'en 2025, si possible. Merci. Merci à vous. Et ça ici, ce sont quelques illustrations du lancement officiel, de la vaccination symbolique. Et nous disons que dans ce contexte de la pandémie à COVID-19, il y a vraiment eu un grand défi d'ordre communicationnel et grâce aux efforts conjugués du PEV et de tous ses partenaires, nous avons pu relever le défi et arriver à vacciner près de 15 millions d'habitants et nous continuons à poursuivre jusqu'en 2024 ou 2025 pour vacciner le reste des populations. Merci.
Merci beaucoup, Dr. Nicole Lubanda, and thank you for stepping in at short notice. Our final presentation for this session is from the Republic of Congo by Dr. Edward Ndinga, who is the focal point for immunization and vaccine development at the World Health Organization. Over to you, please.
Bonjour à tous. Je suis donc Dr. Edward Ndinga, comme vous l'avez dit, et je parle pour l'élimination de la fièvre jaune au Congo. Slide. OK. Notre présentation sera basée sur les chapitres suivants. On y aura une introduction. On parlera de la stratégie au niveau du Congo pour l'élimination de la fièvre jaune, des mesures préventives qui sont prises et du suivi, de l'état de pratique de la campagne préventive que nous comptons organiser d'ici la fin de l'année et les prochaines étapes avec les leçons apprises pour conclure avec les défis. Suivant. Prochaine slide, s'il vous plaît. OK, si là, c'est le Congo que nous présentons pour dire que c'est un pays de 5 753 739 habitants, selon le recensement de 2007. Il faut dire que ce qui est plus important ici, là, à dire que la végétation du pays est à prédominance forestière, ce qui explique cette tendance-là de AEDS dans ces zones-là. Donc, cette tendance à la fièvre jaune. Donc, à partir de là, une étude a été faite, sinon une évaluation a été faite avec les collègues d'AFO et il avait été démontré que le pays est à risque de fièvre jaune. D'où le pays a intégré la stratégie EE en 2016 afin d'arrêter avec les épidémies de fièvre jaune au niveau de l'Afrique. Suivant. Alors, quelles sont les stratégies d'élimination que nous utilisons au Congo contre la fièvre jaune? La vaccination systématique, elle est mise en place depuis 2004 avec effectivement l'appui de Gavi et les vaccins sont donnés gratuitement et l'âge cible, c'est 9 mois. La deuxième stratégie que nous utilisons, elle est liée aux campagnes de vaccination, en campagne contre les flambées surtout. Et nous en avons eu trois ripostes vaccinales, mais localisées parce que c'est des cas sabbatiques. Et ils ont été organisés dans la cuvette ouest en 2009 et en 2013. Au fait, la cuvette ouest, c'est la partie du Congo qui est dans la grande forêt équatoriale. Et au niveau de Pointe-Noire, nous en avons une épidémie qui a été ripostée en 2018. Si les deux premières campagnes, au fait, les résultats n'ont pas été satisfaisants comme on le voit, mais en 2018, ça a été une grande campagne où nous avons eu l'appui d'AFRO, de IST, et le pays s'est mis avec toute la rigueur. Les résultats ont été très, très probants et acceptés. Suivant. Et je voulais dire que pendant ces campagnes de Pointe-Noire, il y a eu, comme les autres l'ont dit, le monitorage indépendant, le maintien indépendant pour prouver combien, pour certifier de la qualité de cette campagne. La troisième stratégie, c'est la vaccination obligatoire des voyageurs selon le RSI et ça, c'est appliqué également à nos portes d'entrée. Suivant. Alors, la quatrième, ça sera la grande campagne préventive que nous allons organiser en cette fin d'année du 26 novembre au 6 décembre. Donc, voilà à peu près les stratégies que nous prenons au Congo, sans pour autant oublier que nous avions la surveillance que nous faisons au quotidien, que ce soit de la manière passive ou que ce soit de la manière au cas par cas. Suivant. Alors, comme je disais, des mesures préventives, toujours nous avons la surveillance avec l'approche SMIR, là où il y a toutes les tendances et qui sont analysées. Nous utilisons la base de DHS2 actuellement qui est en train de se mettre en place au pays. Mais la surveillance au cas par cas se fait de la manière où tous les cas suspectés sont prélevés et les échantillons sont envoyés à Brazzaville parce que le laboratoire national est en double aveugle avec RDC, mais sinon que pour le moment, le laboratoire de référence du Congo, c'est la RDC, l'INRB. Mais toutefois, Brazzaville a déjà commencé à travailler en double aveugle, comme j'ai dit, avec Kinshasa. Suivant. Toujours au niveau de la prévention, je disais que le laboratoire a été également renforcé, le laboratoire du Congo avec l'appui de Gavi, là où il y a une disponibilité de réactifs et les résultats commencent à se faire voir puisqu'ils commencent à partager avec nous. Mais dans le cadre de la surveillance même épidémiologie de la maladie. En 2020, comme vous avez pu le comprendre dans nos pays, là où la COVID est passée, il y a eu baisse de l'activité de surveillance. L'activité de surveillance où nous avions moins de 80% des décès sanitaires avaient notifié au moins un cas. Mais il y avait eu 3 cas IgM positifs qui ont été envoyés au laboratoire de référence dont les résultats ne sont pas parvenus jusque-là et nous avions pensé que ça devait être négatif. Suivant. Et en 2021, à la 4e semaine épidémiologique que nous sommes, il y a eu amélioration au cadre de la surveillance où plus de 80% des décès sanitaires ont notifié des cas. Il faut dire essentiellement que les cas sont souvent notifiés à Pointe-Noire et à Brazzaville et qui font objet de suivi et d'investigation en cas de notification de positivité première ou encore de confirmation. Suivant. Alors ici, c'est la carte, comme je vous ai dit, de notre surveillance. Comme vous voyez, la plupart des départements et des décisions sont en vert, mais il y a des districts au niveau du nord et au centre et au sud également qui sont rouges. Et c'est là où, en 2020, il y en avait plus de districts en rouge, mais en 2020, ça a diminué. Mais ce n'est pas tout. Nous sommes en train de travailler pour que toute la carte soit verte, surtout dans les zones où les accès sont difficiles de la Likwala et aussi au niveau de l'île Mbamou à Brazzaville, parce que c'est intercalé avec le feu. Suivant. Alors ici, il s'agit, comme j'ai parlé surveillance, j'ai parlé laboratoire, maintenant de la couverture vaccinale. Nous avons prévu ici la couverture vaccinale de 2005 à 2021. Et nous constatons que seul en 2011, où les couvertures ont dépassé, nationales ont dépassé 80%. Mais au niveau à partir de 2012, les tendances à la baisse de couverture ont commencé et ça, ce qui expose de plus en plus le pays aux épidémies. En 2021, à maintenant, à la date d'aujourd'hui, la couverture de 61%, ce qui est très, très faible. À vous. Suivant. Ça, c'est la cartographie de notre pays par rapport à la couverture vaccinale et comme on le voit, beaucoup de départements sont en rouge et ce qui met le pays, qui expose le pays aux épidémies de fièvre jaune. Suivant. Là, nous avons tous comparé les deux années, mais vous voyez que malgré quelques efforts qui sont faits en 2021, mais il y a encore des départements entiers qui ne satisfont pas aux critères de bonne surveillance de la fièvre jaune. Suivant. Alors, étant donné que le pays est dans la stratégie EIE et avait soumis sa proposition en Gavi qui a été acceptée, donc il est fait que le pays doit préparer une campagne préventive. Et de cette campagne préventive, nous avions donc déjà au niveau de la coordination, les choses ont commencé avec un comité de coordination par notre ministre qui a été mis en place, qui a commencé à travailler et qui a préparé un CCA qui s'est tenu il y a une semaine. Et ce CCA-là a validé donc le plan de mise en œuvre de la campagne avec comme date du 26 novembre au 6 décembre. Suivant. Bon, la planification également est en train de se faire pour finaliser avec les micro-plans et les chronogrammes afin de dégager tous les gaps qui se feront sentir et mobiliser les ressources. Suivant. Le plan de communication est très, très important pour nous. Il est en train de se travailler parce que, combiné avec la communication avec la COVID, il y a donc lieu qu'on travaille sérieusement, étant donné que le pays a vraiment mis l'accent sur la riposte contre la COVID, avec l'opération qu'on appelait coup de poing contre la COVID. Donc, cela demande que si on veut tenir la campagne au même moment, il faudrait que la communication aille ensemble et soit vraiment forte et ne soit pas confuse. Autrement dit, on risque d'avoir un échec. Suivant. Alors, sur les prochaines étapes, on va toujours, la coordination va continuer à fonctionner avec l'adoption de tous les outils et tenir le plus tôt vite possible les micro-plans, faire le point et valider les plans de communication afin de mobiliser les ressources et pour estimer être prêt aux dates prescrites pour faire l'activité. Suivant. J'ai déjà dit pour les planifications, on est plus, la priorité devient aux activités de micro-planification et également la communication vient à vite finir le plan de communication en associant diverses tendances, en associant les autres ministères de la communication afin d'avoir un plan de communication très solide. Suivant. La logistique, c'est aussi un problème important. La logistique, il y a la chaîne de froid, mais nous savons que par le CCOP, le PEF est en train de recevoir du matériel et qui va certainement beaucoup contribuer à la logistique de la chaîne de froid pendant cette campagne. Les micro-planifications vont également nous aider à voir là où il y a des problèmes pour trouver vite des solutions de mitigation. L'expédition des vaccins et le plan de distribution est prêt, mais on attend que les choses se reprécisent pour qu'on envoie le vaccin. Mais ce que nous, on va essayer un peu de mettre l'accent sur l'iniquité vaccinale. Là, nous pensons que le Congo a eu une très, très bonne expérience pendant la COVID et pendant la campagne de polio sur l'iniquité vaccinale et nous comptons mettre ça à profit pour cette campagne de vaccination préventive contre la fièvre jaune. Et ça, c'est un acquis. Nous devons travailler beaucoup là-dessus parce qu'il y a des acquis qui sont déjà là. Suivant. Bon, qu'est-ce que nous pouvons apprendre comme leçon? Suivant. Slide. Bon, le succès de cette campagne pour nous dépend de plusieurs choses que nous avions apprises pendant la campagne polio, avec la digitalisation des parcours des équipes, avec l'identification des zones qui n'ont pas été atteintes. Et aussi, nous comptons sur l'engagement politico-administratif pour un niveau local, que tous les professeurs, toutes les autorités soient impliquées dans la campagne pour vraiment organiser une bonne réussite, comme cela a été fait pour les campagnes polio passées. Aussi, nous comptons sur la communauté qui, en ce moment avec la COVID, est dans un doute et qui est dans une déni de maladie de COVID. Donc, on doit travailler de telle sorte qu'ils adhèrent massivement à notre campagne de fièvre jaune sans pourtant qu'on prête confusion. Suivant. Bon, nous allons mettre, on va utiliser actuellement toutes les technologies possibles de suivi d'une campagne, d'une bonne campagne pour que notre campagne soit un succès. Suivant. Alors, les défis, c'est comme les autres l'ont dit aujourd'hui. Nous, on va prendre l'exemple des autres. On prendra seulement les leçons tirées par les autres et les bonnes pratiques des autres qui ont fait cette campagne au même moment qu'il y a la riposte à la COVID pour éviter toute interprétation biaisée, surtout que c'est injectable comme la COVID. Donc là aussi, c'est un travail et nous comptons sur les expériences des uns des autres pays qui ont fait ça pour qu'on s'en sorte. Toujours la campagne de vaccination avec, comme j'ai dit, que nous voulons mener, il y a une grande opération coup de poing contre la COVID et les ressources restent les mêmes, je dis ressources humaines restent les mêmes. Les moyens logistiques vont rester là puisque le PEV, la vaccination est en avant. C'est en avant dans cette opération coup de poing. C'est vraiment l'épine dorsale de cette opération coup de poing. Donc, les ressources seront les mêmes, que ce soit humaine, que ce soit logistique. Pourquoi pas financière? Donc, légalement, nous pensons que c'est un grand défi à relever pour que les choses soient un peu plus claires afin de donner toute la possibilité à notre campagne de vouloir s'exprimer et amener à bien les actions qui sont retenues. Suivant. Alors, voilà ce que je tenais à vous dire par rapport au Congo. Je vous remercie pour votre aimable attention. Merci.
Merci beaucoup, Dr. Nicole Lubanda, Dr. Edward Nadinga, and of course, Dr. Terana. We are now opening the floor for Q&A, but before we do, I would like to echo Dr. Terana's sentiments, and I think we all join him in applauding the on-the-ground champions for the extraordinary effort going on during the pandemic. Our first question is from Nigeria, and here it is. Can the country describe any more top pieces of advice for success in multi-antigen vaccination campaigns? Dr. Terana, if you're still there, over to you.
Okay, so thank you very much. So for us, it's been, will I say, a learning curve for every single campaign that goes on. I think what is clear is to be setting based on the resources you have available, i.e. the health workers or the cold chain equipment that you have on ground and the capacity for teams to adhere to the guidelines. There are two things which we focused on, and for us, because of the huge scale, it was clearly the issue around supportive supervision. So for every single district or LGA that was implementing the integrated campaign, we had some high-level supervisor who was on ground, ensuring that we had the teams adhere to the guidelines. The other thing too was just to be sure that we didn't have any cross-vaccination or stuff. We had different Joe styles or cold chain boxes or equipment that were clearly labeled that was being offered at that post. So where you had 2 or 3 vaccinators, cold box or vaccine carrier was labeled with either measles or with men A moving forward. One other thing we have also seen, particularly when it relates to yellow fever, because yellow fever brings out a huge crowd of people. For Nigeria, we're targeting 9 months to 44 years. So that automatically means that all the target person for all the other antigens falling. So everyone who is mobilized the post for yellow fever, if it's an adult, will usually come in with their child who will either get the measles or MNA jab and things like that. The last thing I will say will be in terms of resources and the mobilization. We clearly see that we're a bit more efficient with the integrated approach. So activities like the trainings, like the social mobilization activities are all done collectively as one, and it just gives that whole health approach. So everybody who basically comes into the vaccination post is eligible to receive one intervention or the other. So I think those will be the 3 things that I'd like to mention in terms of the integration. Thank you.
Thank you so much, Dr. Terana. And yes, efficiency is the key word. We have a question for the Democratic Republic of the Congo. It seems there were considerable logistical challenges where the team needed to find creative solutions quickly. What would be your top advice for other countries to anticipate similar challenges and how they could also overcome? For example, what were your keys to success?
Merci beaucoup pour la question. En fait, les obstacles logistiques au niveau de la RDC sont d'abord d'ordre... bon, on avait une faible couverture en matériel de chaîne de froid par endroit, c'est vrai, et nous avons mis un système de réapprovisionnement régulier des sites de vaccination grâce à des glacières et à toute la logistique qui a été mise en place, et surtout pour certaines zones d'accès difficiles avec les intempéries, et également de l'autre côté avec l'accessibilité géographique due à l'accessibilité par voie fluviale. Donc, nous avions deux cas de figure. Il y a des provinces qui présentent une accessibilité routière très difficile, raison pour laquelle nous avions mis en place des moyens nécessaires pour pouvoir acheminer les vaccins vers les lieux de prestation de services. Mais de l'autre côté, nous avions donné aussi l'opportunité aux provinces de pouvoir réorganiser leur logistique pour que toutes les zones de santé soient servies dans le délai et que nous puissions atteindre notre objectif. Merci.
Merci, Beko. Please, there is a question for you in the Q&A section, if you could address it at your own time. With this, we come to an end to this session, and I thank you very much for your engagement. We're going to take a little break now. We're going to reduce it from 15 to 10 minutes. So please grab some refreshments, and please, we hope to see you back in the next 10 minutes. As we move on to the working group presentations, I know we are all excited about them. So please hope to see you back in 10 minutes. Thank you. Welcome back, everyone. I think we can begin our next session. Yes, okay. I hope you all are geared up for the next session that will engage all of us as it's time for our working group presentations. But before we go into that, there is a little note for all speakers to please try to keep to time. I know we are all passionate about the work we do and want to present it, but we do have time to keep, so please do that. And also to our translators who are doing a great job, this is to let you know they would be moving on at 6 o'clock. So we will be with our translator supports after that. If Nicole Lindsay is ready, we would like to move to the risk analysis working group. I give the floor to Nicole Lindsay, who is the epidemiologist for the US Center for Disease Control. Over to you.
Thank you, Priyanka. Can you hear me all right?
Perfect, thank you.
Okay, great. I'm really pleased to have the opportunity to provide an update on the behalf of the Risk Analysis Working Group today. Before I discuss our updates, I just wanted to review the primary goal of the Risk Analysis Working Group, which is to develop a simple to use and evidence-informed approach to assess yellow fever risk in countries considered to be at high risk for epidemics. Whoops. Can you go back, please? These assessments are needed to provide objective input to support operational planning and to allow for prioritization of campaigns both between countries using a national level tool and within countries using a subnational tool. Next slide. So I'll start with just a few updates related to our work on the national level risk assessment. To develop this tool, we began with a simple approach that involved awarding points for the presence of various factors that influence yellow fever transmission, with more weight or higher points awarded for more recent events. This tool is meant to estimate risk based on existing data. It's not meant to be a predictive tool in terms of locations where the next outbreak might occur. So we focused on key variables to help define endemic and epidemic yellow fever risk and included estimates of existing population vaccination coverage from routine programs and mass vaccination campaigns. We pilot tested the tools with a few countries and identified and implemented some improvements, working with global experts on the working group. I seem to have lost the slides. Other eye partners and with in-country representatives. A version of the national tool developed for use in African nations was published in October of last year. You can go to the next slide, thank you. So in June of this year, the I Secretariat requested an updated risk ranking of countries to help guide discussions of annual vaccine allocations. Risk assessment scores are one of many inputs that are considered in determining those allocations. So the data that populate the tool were updated to include the final 2020 data and also mid-year 2021 data. And I'd just like to acknowledge that this work was completed by a WHO consultant, Rebecca Casey. Next slide. So this map shows the changes in scores among countries assessed using the tool, comparing 2020 and 2021 scores. The 13 countries in red had higher risk scores in 2021. The 11 in orange had no change in score. And the 3 in green had lower risk scores in 2021 compared to 2020. Next slide. So I'm just going to briefly discuss some of the major drivers of the changes in scores. Firstly, several countries in West and Central Africa, namely Cameroon, Burkina Faso, Cote d'Ivoire, Togo, Senegal, and Chad, reported confirmed yellow fever cases after several years without reported cases. So this not only increased the risk scores in those countries, but also in neighboring countries, given how the tool calculates risks. Unfortunately, none of the 27 high-risk countries were able to achieve routine yellow fever immunization coverage of greater than or equal to 90% in 2020. Average national vaccination coverage for all countries decreased by about 3% between 2020 and 2021. I will note that the Democratic Republic of Congo was able to achieve a lower risk score due to very successful preventive mass vaccination campaigns. So this just outlines some of our next steps for the national tool. Our work group has reviewed and discussed the updated scores, and we are currently evaluating some more direct measures or data sources, in particular for the measurement of healthcare infrastructure to respond to outbreaks. We are proposing to update the national scores twice annually moving forward, with one update occurring in January to include final calendar year data, and then a second update in June to help inform those annual vaccine allocations. We are going to continue to evaluate the included data inputs to the scoring matrix to ensure standardization and also inclusion of the most accurate data sources. And some working group members will also be consulting with our PAHO colleagues as they develop a risk assessment tool for their region. So next slide. My last slide summarizes our work on the subnational assessment tool. Next. So just to review quickly, the objectives of the subnational tool are to assist countries in determining relative risk of yellow fever in subnational administrative areas to guide planning for phased preventive campaigns where they're necessary. We anticipate that only certain high-risk countries with large at-risk unvaccinated populations will really need to do these subnational assessments. The tool is not designed to compare areas between countries at subnational levels, and it is also not designed to assess current risk or risk of future outbreaks based on recent changes in the epidemiologic situation. So there are just a few differences in the approach to the subnational tool as compared to the national tool, and some of those are outlined here. In developing the national tool, we used several surrogate data inputs instead of direct measurements of yellow fever risk. So, for example, we included a variable that captured land cover for the different countries instead of non-human primate distribution. Surrogates were necessary in building that tool because many specific data inputs were not really uniformly available for all countries that we were assessing. It's our hope that the subnational tool will allow for the use of more direct measures, as hopefully those data gaps may be more uniformly available within a given country. Additionally, the subnational tool has been constructed to allow for more flexibility to accommodate local needs and local data sources. So next slide. So this slide just outlines our planned activities for the subnational tool for the coming year. Unfortunately, we weren't really able to make as much progress as we had planned to in the past year, at least in part to COVID responses and other competing priorities. We've experienced some challenges in balancing the need for flexibility to be able to tailor the tool to, as discussed, in-country needs and available data sources, while also maintaining some standardization in the tool and how it's used. So we've been able to pilot earlier versions of the tool with a few countries, including Uganda, Republic of Congo, and Nigeria. In the next year, we hope to continue to pilot the tool with selected countries with the capacity to engage, and we are currently working with some colleagues in Ethiopia. Once we have some more experience with the tool, we'll have more discussions with our working group and the country representatives on the piloted approach, discussing some potential limitations and some solutions to address those. And by the end of next year, anyway, we hope to finalize and publish the subnational risk assessment tool for use in high-risk African nations. So next slide. I just wanted to close by thanking all the members of the Risk Analysis Working Group and our partners for their important contributions to this work. So, thank you.
Thank you so much, Nicole, and thank you for staying very much on time. Thank you. Please, participants, I really appreciate your questions. Keep them coming. We have Dr. Erin Staples, who's also available to address them at the end of the next session, which is the Lab Technical Working Group. And for that, we have with us Jean-Francois Lemaire, who is the Technical Officer within the laboratory at the World Health Organization. Dr. Mike Mulders from this working group will also be available for questions after this presentation. So over to you. Thank you.
Thank you very much, Priyanka. And it's very an honor for me to present this presentation, which was put together by me and my colleague, Dr. Mick Mulders, and I'm presenting it really on behalf of the entire Laboratory Technical Working Group. Next. So as it was mentioned many times in the previous presentation today and yesterday that the need for high quality laboratory diagnostic is obvious. But one of the reasons why it is so obvious is because only the lab diagnostic testing of a suspected yellow fever cases can confirm clinical suspicion. And these are due to a few reasons, and notably because the clinical progression is biphasic, meaning that we have different phases. We have one phase where has a lot of viremia, and another one which is a more severe phase where we're looking more at clinical symptoms such as jaundice. Many other diseases will have similar clinical symptoms, including jaundice. And the recognition of yellow fever cases in early stages of outbreak is actually rather difficult. So, and all of this leads really to the high necessity of the final case classification through laboratory diagnostic. So having a reliable, timely, and complete surveillance data with laboratory diagnostic testing really guides the yellow fever control programs. Next. So capitalizing on previous investment in polio, measles, and rubella, in 2005, WHO established the Yellow Fever Laboratory Network in the region of the Americas and the African region. And that has been mainly to standardize the different standard operating procedures, as well as the validation of novel methods and capacity building. We're very lucky to have a global specialized laboratory, being CDC Fort Collins, that is helping us in the network. But we also can capitalize on three key regional reference laboratories in the African region. So the Institut Pasteur Dakar, the Uganda Virus Research Institute, and the Centre Pasteur Cameroon. And in the Americas, we have a number of WHO collaborating centers, including Mexico, Argentina, Cuba, and USA. Overall, the network is composed of 68 laboratories total, 30 national laboratories in 26 countries in the Americas, 37 national laboratories in 32 African of the Afro region, as well as one national laboratory in the EMRO region. Next. So really, the Laboratory Technical Working Group is there to address various challenges that has been noticed over the years. And this is really, trying to improve the diagnostic capacity to detect yellow fever in a reliable and timely fashion. What was described before is existing laboratories were underperforming, and some yellow fever laboratory capacity was even missing in some high-risk countries. Ensuring sustainability is also has been and is still a challenge in terms of financial sustainability, as well as human resources and the staff capacity in terms of number of tests that can be performed, but also in terms of technical skills. The timely provision of laboratory supplies to keep the network laboratories has also been identified as being a challenge, as well as ensuring that we maintain over time laboratory performance. If we look at the members of the working group, we have a high variety of members, including different institutions such as the US CDC, Erasmus. We have institute in the Netherlands, in Germany with the Habakkuk Institute. We have Gavi, we have some consultants as technical advisor, as well as all the regional reference labs that I mentioned, along with all our regional WHO offices and UNICEF Supply Division. Next. Some of the key highlights since the last partner meeting are mentioned here, and I'll go just briefly through it. One of them is the appointment of a new global yellow fever network coordinator that is joining the WHO team that was already in place. And I'm really happy to fulfill that role. There's been also two new regional reference laboratories that have been nominated since the last partners meeting, namely CPC in Cameroon and the Uganda Virus Research Institute. And there are also three new national reference laboratories in Nigeria and Brazza. We have, in terms of kit performance evaluation, a number of progress as well, notably the molecular kit performance evaluation, for which an expression of interest has been closed, and then the performance has been completed, and the report is now published. In terms of the serology kit performance, the expression of interest has been published and closed. The serum panels were built by US CDC, the evaluation was done by ITM in-network, and the report is still pending, but it will be available very soon. We are also looking at now the antibody rapid test evaluation, which the EOI has been closed, and the kit evaluation is underway as we speak. Serology EQA, this is very much in good progress, about to send the specimen to the countries, and we are expecting the first results early 2022. A number of training has been done since the last meeting, hands-on training, and some are even planned for 3 weeks from now, as well as next month. Laboratory manual, it's well on its way. It's also going to be looking at a revision, and it's progressing well, and we're looking at completion of a technical review, probably by end of this year or early next year. We have speed up the case confirmation through international simple transportation, and also in terms of procurement with coordination with the Gavi and UNICEF Supply Division, we have shifted from a WHO standalone procurement to a procurement of reagent bundles, which facilitate the procurement of serology reagents. And we're looking at addition of new commercial assays in the same model. Gavi support has been approved for 2022 by Gavi board, and we're looking at various R&D projects, such as FDA cards to ease the transportation of specimen, etc. Next. So some of the challenge that we have faced since the last meeting is the quality and quantity of specimens that are being referred to the regional reference lab being either too low, too little, or hemolyzed. We have been facing important challenges in terms of incomplete information on the laboratory forms, which are critical for the final case confirmation, and notably these are the history of immunization from the patient and other clinical histories such as symptom onset. Some challenge also between linking the surveillance and the laboratory with regards to notification data and reporting infrastructure. So we're going to be looking at trying to improve that over the next year. The ordering process of some of the new assay, notably the molecular assay, is quite tedious, and we have started and learning the process, but it has been a challenge so far. We have to improve as well some linkage between the different working groups, and as we have discussed and many others have mentioned, the COVID situation has really hindered the activity of the working group, especially in terms of participating in training workshops, and also having different delays and the staff in the region and in the laboratories being stretched very, very thin, as well as the coordinating staff in the WHO offices. And the sustainability to maintain this the global yellow fever laboratory network is also a remaining challenge, because we know that Gavi support is time limited, and we also need very strong country buy-in. Next. So just 1 second to say that so far we have made good progress against our work plan, and we have, as of today, reached 64% of our work plan, and these are the details in the different big categories. Next. So in the next year, we're looking at finalizing the serology MAC ELISA, as well as the IgM rapid test evaluation, and publish those findings. We're looking at adjusting the testing algorithm towards an easier interpretation and clear way forwards, integrating both clinical and immunization history. We're planning to open a second expression of interest for the collaboration of more commercial molecular tests for yellow fever. We are looking at revising and finalizing, publishing the revised laboratory manual. We are going to have regional serology and molecular testing training before the end of this year, both for Anglophone and Francophone countries. And we are looking at renewal of financial support to all regional reference lab for routine surveillance activities. Next. On that, I really like to acknowledge the contribution of all members of the Laboratory Technical Working Group, as well as all our key partners listed here. Thank you very much.
Thank you very much. Nicole, Dr. Staples, Jean Francois, Dr. Mick Mulders, thank you very much for being with us. We have some questions for you. And also, participants, I request you to continue to drop your questions either in the app or in the Q&A section in Zoom. And we have for the National Technical Working Group, we have a question here. Want to know, the National Technical Working Teams are not included in the RAWG. How will the national teams be involved in the RAWG? What is the plan for the step down for the assessment to the national teams? Who would like to take this question?
Sure, this is Erin Staples. I'm the head of the Risk Analysis Working Group. I'll go ahead and take that question. So the national tool itself is really one of many different things, as already noted by Nicole, that's used by the I Secretariat to determine vaccine allocations on an annual year. The tool uses inputs that are available for all countries, and as noted, sometimes uses a surrogate. We do have representatives from various backgrounds, including virologists to entomologists to epidemiologists. So you actually will find that Olawale Tamori from Nigeria is representing his experience on that group. So in terms of the step down is more involving when it gets to the subnational level. And that's where there's definitely a role for interacting with the country to make sure that we realize and can articulate the risk, between areas of the country to help in prioritization of vaccination campaigns. So I hope that answers the question. Back to you.
Thank you very much. I think that does. We have another question. Since the detection of antigens for yellow fever is not widely available test, could you elaborate on the information about the antigen tests that you have mentioned? Are they commercial tests?
Thank you. Maybe I can take this question. So thank you very much for the question. As part of the Laboratory Technical Working Group, we're looking at also the landscape of what is about to come on the market, especially also to guide what is our next step in terms of kit performance evaluation, but also to see how the working group can contribute on the research and development and guiding research and development efforts. So in terms of the antigen assay that I was referring to, it's a rapid test. There are some working at right now developing, and they have developed an S1 assay. It's not commercially available right now, and we are communicating regularly with the manufacturer as well as the different collaborative center that or doing some evaluation of this essay to really keep up to date of what's coming up and make sure that we make a recommendation and also kit performance evaluation in a timely manner. I hope this answered your question.
Thank you. And please, we have another question for you before you go. Since the detection, my apologies. Is there a possibility of developing RTDs for the yellow fever diagnosis in low middle income countries?
So thank you very much. So so RDTs, if I'm not mistaken, right?
Yes, RTDs.
Okay, so at the moment there is so a rapid diagnostic test. So there's an antibody-based rapid diagnostic test, and we will be an expression of interest has been submitted, open, and is now closed. We have received application from a manufacturer, and we are going to evaluate the performance of this product before the end of the year. So that's one, and it's commercially available. And if found successful, then we will make a relevant recommendation for use. In terms of antigen-based rapid tests, there's also the one that I mentioned, the NS1, which is not yet commercially available, but is expected to be available at a reasonable cost and yes, for the market that you mentioned. But we're looking, as I mentioned, we're coordinating with the manufacturer and other groups that are doing different evaluation in order to make sure that we run the performance of this assay in due time. And maybe my colleague, Nick Mulders, may have something to add.
Yes, Dr. Mulders, we would love to hear from you.
We can't hear you, Mick. Can anyone else hear him?
While he's...
Can you hear me now?
Oh, yes, yeah.
Sorry for that. I had another microphone on. Thanks, Jeff, for covering me. Apologies that I'm dropping in so late, and I had some other more urgent issues to deal with. Great comment. I think one of the things I wanted to raise was the fact that together with the support from Gavi, we are working towards introduction of these RDTs in low middle income countries, particularly in Gavi eligible countries. So this is really to help priority countries for yellow fever to be able to have diagnostics available, preferably rapid diagnostics available for understanding the outbreaks that are happening and the support that we can give from our network. Thank you very much.
Thank you so much. We have another question for the RAWG group. How would you envision the tool will be further refined for moderate and potential risk countries?
Yeah, thank you. This is Erin again. So we have started on some discussions with moderate risk countries. I think the bigger question, it's using a very similar tool, which is geared towards high-risk countries where you're really measuring the cumulative yellow fever risk, where moderate risk countries have had very infrequent or no human disease cases. So, it depends on the actual outcome and the deliverables that need to be focused for the moderate risk. I think by itself, it would obviously provide low scores, which in comparison to high-risk countries would be appropriate, but also, how to translate that better into public health action in terms of improving surveillance or potential considerations of EPI or other things. That's something that we're currently working with our partners at the WHO Secretariat. I appreciate that question, and it's something that we're considering and moving forward. Over.
Yes, thank you very much. We have a hand raised from NCDC. Would our participant like to come in, please?
Okay. Good evening, all.
Good evening.
Yeah, my name is Wachuku William. I lead the Yellow Fever Technical Working Group at NCDC. Yeah, number one, I really want to appreciate the good works in ensuring that the laboratory services of the yellow fever response is optimum. So thank you for that. At least we have additional 2 laboratories, and these are in such a way that the proximity to the states are now nearer than what we had before. Then, following Dr. Chikwe's presentation yesterday on the use of PCR, at least to confirm, and also leveraging on the COVID-19 response capacities, which with it, we've been able to get a lot of PCR machines functional in so many states. Can we leverage on these PCR machines across the states to increase the number of PCR testing in Nigeria and vis-a-vis to other countries? How possible can this be? Thank you.
Thank you very much. Dr. Erin, would you like to take this up? Or Dr. Mulders?
I'll turn it over to the lab work group to address that. That's
okay. Can you hear me?
Yes.
Oh, thank you. Thank you for your question. Really very great to find the commitment at the national level to support laboratory diagnostics and to enhance it. For PCR, it's a little bit complicated because it's not an easy test. There is really some training needed, and that's what we are trying to do, working with quite a few Nigerian laboratories to expand laboratory capacity. Dr. Maurice Demanu from WHO Afro is key in training a lot of laboratories in the region moving forward to enhance laboratory diagnostics. It is not such an easy test, and then therefore you need a trained laboratory. What is interesting is that we are working now with RDTs, and RDTs are perhaps easier to use, and particularly at the front line of the outbreaks, be able to confirm outbreaks that can then be investigated more deeper by the laboratories in the network. I hope that satisfies your answer. Over.
Thank you so much. Thank you to all the speakers and Dr. Mulders for being there. We would like to move on to the demand and supply working group. So we have with us Hans Christensen, who will be presenting on behalf of the group. Please submit your questions in the Q&A section here in the app or on the Zoom. Over to you.
Thank you so much, Priyanka. Good afternoon, good morning, good evening. Thank you so much for giving me the opportunity to present today on behalf of the Demand and Supply Working Group. I am Hans Christensen. I am together with Antonia, Bill, and Andrew, also available today. I work in the UNICEF Supply Division. I'm a contract manager, and I oversee the procurement and supply of yellow fever vaccine amongst a number of other antigens. Next slide, please. So apart from the work of the Demand and Supply Working Group, I will present today the outcome of the most recent tender for yellow fever vaccines during 2021 through 2024, and thereby also the outlook for yellow fever vaccine supply through UNICEF during the same period. Next slide, please. But first, this slide gives you a representation of the work of the Demand and Supply Working Group. We are focusing on the monitoring, collection, and dissemination of information regarding the yellow fever market, with a focus on accurate demand forecasting and projecting vaccine availability from manufacturers. Since the I strategy inception, additional countries have introduced the vaccine, and more countries have conducted preventive mass vaccination campaigns. But as we've heard over the last couple of days, the job isn't done yet. And the Demand and Supply Working Group therefore assists the I strategy and us at Supply Division to project the timing of these events and the forecasting of the demand to support these additional activities in countries. Next slide, please. So this slide shows the specific work plan for 2021 for the working group. Just a few weeks ago, the working group hosted a session with the aim of establishing a calendar including all the projected mass vaccination campaigns in Africa. We're still some way to go to have this finalized, but UNICEF and partners will use this tool to improve planning and market communication going forward, while we ensure that it's kept up to date and thereby includes the most recent plans and forecasts from countries and partners. Next slide, please. I'll now try to make a gentle transition to also give you an overview of the activities related to procurement and supply of yellow fever vaccine through UNICEF. So this slide shows you the historic procurement of yellow fever on behalf of countries that procure through UNICEF, plus the forecasted demand for the same countries during 2022 through 2024. The forecast represents what is projected for all program categories. That means routine programs, preventive mass vaccination campaigns, and the emergency stockpile. By 2024, we forecast that these activities in these countries will require 130 million doses. The increase, as you see in this slide, is predominantly expected to come from the increased use of yellow fever vaccine in the preventive campaigns. Next slide, please. So like the projected increase in the forecasted future demand primarily will come from increased use in preventive campaigns. This slide shows you that the increased supply to the 6 countries that have implemented preventive campaigns over the last 5 years. So prior to 5 years ago, supply availability did enable this program activity, but not at all to this level that we can see here. So you will see that the countries that were supplied was Nigeria, DR Congo, Ghana, Angola, Sudan, and Congo. And since 5 years ago, a total of 191 million doses have been supplied for preventive mass vaccination campaigns. Next slide, please. Yeah. So since the last outbreaks of yellow fever in Angola and DRC in 2016, suppliers have consistently made vaccines available also for the emergency stockpile and have enabled our rapid response to countries requesting access to vaccines to counter outbreaks. And so over the last 5 years, 26 million doses have been supplied to 8 countries experiencing outbreaks. You see in this slide that the use of the emergency stockpile and the supply to outbreaks is due to the nature of outbreaks is variable and this is by nature really difficult to project and forecast. My last couple of slides, I'll turn to the outlook for the coming years. We in supply division have recently concluded the tender for supply during 2021 through 2024. We are very thankful to our suppliers for their participation and continued commitment to combating yellow fever through production and supply of the vaccine to all program categories. We have established supply agreements with 4 suppliers until 2024. We're very pleased that offers from suppliers allows us to project increased availability and will therefore permit increased supply to also preventive campaigns during this period. And we project that that supply will reach 60 million doses by 2024. This will be my last slide, and I will end it by giving you a few key updates and messages. So with the promising outcome of the tender, we project that the supply of yellow fever through UNICEF will increase by 6 to 9% annually in the next years. In order to facilitate and sustain this increase, the partnership and countries will have to focus on improved planning of preventive campaigns, which includes submission of timely applications to Gavi for their support. It is key that our planning for the preventive campaigns improve, our forecasting for preventive campaigns improve to enable supply production of increased quantities for this activity. And lastly, we at UNICEF will continue to work closely with our vaccine suppliers to enable appropriate and accurate supply planning to accommodate this increased country demand. Thank you, Priya.
Thank you so much, Hans. And yes, we hope we can achieve our targets as always. Thank you. Our final presentation for the day will be delivered by Dr. Alex Roswell, who is the Technical Officer in Vaccine Preventable Disease Outbreak for the World Health Organization. Again, please submit your questions in the usual way, and we may not have interpreters after 6 o'clock. So I hope that we can wrap up this presentation before that. Over to you. Thank you, Alex.
Noted, Priyanka. Thanks very much. I'll try and go quickly. So good afternoon, colleagues. It's great to be with you. So I'm presenting an update on the vaccine delivery working group, and I'm doing this on behalf of the team. And I'd like to just say a quick thank you to Saba and Yodit from UNICEF for sharing many of the slides and helping pull together the summary for today, as well as Yodit for being the chair of the group for the last period of time and for her leadership. Okay, so the content of today's update is going to be a quick look at the yellow fever vaccination coverage estimates from the WUNIC, the WHO UNICEF 2020 data. First, we'll look globally, then region by region, Africa and the Americas. I'll then touch on some of the work that the group has been doing, which includes a national yellow fever policy survey, briefly talk about an information note to support countries to switch from 10-dose to 5-dose vials for yellow fever, and highlight some operational research which is in the pipeline, looking at drivers behind the differences in vaccination coverage. And I'll finish by looking at the work plan for 2022. Next slide. So looking now at the vaccination coverage estimates, so a little bit of a brief on the data. So the aim of the following analyses were to look at the vaccination coverage for yellow fever in 2020, look at how that changed since 2019, and then look at the coverage differentials between the first dose measles and yellow fever. So for the analysis, the coverage analysis included 21 countries in the Afro region and 10 in the Americas, and all of which have introduced yellow fever into routine programming. There were various countries for which data was not available. I won't go through them here. And similarly for the assessment comparing yellow fever and MCV1 trends, that only included countries with data from the national level, and those countries were excluded. Next slide. So this figure here is I guess both regions together, so let's call it global, a median national coverage estimates for MCV1 and yellow fever. And you can see here that both MCV1 and yellow fever coverage in Afro and PAHO countries that administer yellow fever at national level dropped in 2020, as did MCV1. Next slide. Now looking at the Afro region alone. So this is median national MCV1 and yellow fever coverages in the 22 countries from 2010 to 2020. So you'll see that in 2020, the median MCV1 and yellow fever coverages both dropped, and probably the most radical drop from 2019 to 2020, and the lowest median coverage of yellow fever vaccination for that entire period was 58%. And the difference between MCV1 and yellow fever was 4 percentage points, and the largest since 2018. Next slide. So this figure here shows the differences in coverage from 2019 to 2020. So 2019 is the set of bars in light blue across the top, and at the bottom is 2020. And you can see it's broken down by country, and the countries that are highlighted with a red box indicate that there was a drop in coverage irrespective of size. So you'll see that 45% of countries had a yellow fever coverage of greater than 60%, and 20% had yellow fever coverage greater than 80%. And there was a drop in coverage in 11 countries. And you can see Gabon, Liberia, Mali dropped below 60% in 2020. Next slide. This figure here looks at the difference in coverage between MCV1 and yellow fever in the 20 countries in the African region. And so you can see that 45% of the countries had a coverage of less than 60%. 30% have a differential of greater than 5% between measles first dose and yellow fever. And 5 of the 6 countries have a 5% difference between the antigens. and a suboptimal measles and yellow fever coverage of 80 and 60% respectively. And you can see those countries with the 5% difference highlighted with the red dots. Next slide, please. Now looking at the Americas, this is again the median national MCV1 and yellow fever coverages in 10 countries across the same period, 2010 through 2020. And you can see here that 76% was the yellow fever estimate for the region, and the lowest point between 2010 and 2020. And equally in the Americas, there was a 4% coverage difference between MCV1 and yellow fever. And the median MCV1 also dropped in 2020, and 80% was the lowest point also during the same period. Next slide. So the same analysis as per AFRO, this is for the Americas. So 2019 at the top, 2020 at the bottom. And you can see again in red, the countries where coverage dropped. So coverage was greater than 80% in Colombia, Guyana, Paraguay, and Venezuela. But it dropped in 7 of the countries between 2019 and 2020. And Brazil and Suriname had yellow fever coverage less than 60%, both of which had dropped between those years. Next slide. And this is the final analysis for the Americas, looking at the differential between MCV1 and yellow fever across the 8 countries. So 25% of the 8 had coverage below 60% for yellow fever. 25% have a gap of 5% between the coverages, Brazil and Colombia. And 1 of the 8 countries had both the 5% gap between the 2 antigens and suboptimal coverage for both MCV1 and yellow fever. Next slide. So I'm now going to go into some of the work of the vaccine delivery working group. So first up, I'm going to look at the vaccination policy survey that was implemented. So in 2020, the working group surveyed 27 priority countries from the AFRO region. And this was done jointly between WHO and UNICEF and completed with the MOH in English and French. And the survey was aiming to capture the profile of yellow fever vaccination policies, administration of yellow fever as part of routine, funding for routine yellow fever vaccination, vaccination of travelers, as well as country identified barriers to yellow fever vaccination service delivery. And I'm just going to show a few of the findings. Next slide from these sections here. Yeah, so firstly, looking at yellow fever in routine. So this is remembering at the time of the survey. So 23 of the 27 high-risk countries had introduced yellow fever into routine. Of these, 22 administered it at the national and 1 at the subnational level. 4 countries at this time were yet to introduce into the routine. And this has obviously changed since then. Next slide. So now looking at yellow fever in the 2nd year of life. So 61% of the 23 countries that include YF in the routine also include 2nd dose measles in their routine immunization. 12 of the 14 countries have a catch-up policy to vaccinate children who missed vaccinations in the 1st year of life. And 11 of the 12 have catch-up policies that include yellow fever. Next slide. So now looking at vaccination of travelers. So 74% of the 27 countries offered vaccinations to unvaccinated travelers from both arriving from and departing to at-risk countries, and 22% of countries offer vaccination only to departing travelers to at-risk countries, and 1 reported not offering vaccination to unvaccinated travelers. Next slide. And this is the final slide from the policy survey. This looks at financing of yellow fever vaccines and funding gaps. So the figure you see has self-finance countries by government at the top. So that each dot represents a country, and at the bottom row is co-financed by government and Gavi. And so you can see the funding gap countries were those in yellow and the non-funding gap in purple. So 61% of the 23 countries co-finance the procurement of yellow fever vaccines with Gavi, and 39% self-finance for vaccine procurement, and 50% of co-financing countries and 22% of self-financing countries reported gaps in funding in the past 5 years. Next slide. So this is a screenshot of the information note that will be finalized in the coming week or so. And this essentially summarizes evidence on switching from 10-dose to 5-dose vial presentations for yellow fever, describes the currently used vaccine presentations in priority countries, and covers measles and yellow fever. And it outlines some of the planning and operational considerations for countries wishing to make that switch. So it's aimed at decision makers, so national health authorities, as well as the regional bodies such as RITAGs. Next slide. So this one here is providing information on the planned mixed methods research that will be conducted in 2022 as part of the work plan. And this research is really all around trying to understand what's driving these differences between the MCV1 and yellow fever immunization coverages, and looking at it in a range of settings and identifying what also are the potential solutions for this. So I hope that we're able to update the next annual meeting with some of the findings from this work, but it's a 2022 implementation. Next slide. So we now look at the work plan for the vaccine delivery working group. So obviously there'll be work to follow up on the findings of the policy survey. So grouping it by routine and campaigns under the policy survey, advocacy work for the introduction of yellow fever vaccine in the remaining 2 countries. And I just highlight the countries that implemented for this year and a plan for early next year. Advocate for all countries to conduct catch-up vaccination, especially for first-year antigens after the COVID disruptions, and using the second year of life platform optimally for catch-up, and advocating vaccination at points of entry in those countries that were identified. Operational research into yellow fever specific vaccination issues, particularly examining yellow fever and measles. So that's the research I just described, and survey to assess demand in countries for looking to switch from 10-dose to 5-dose vials in the high-risk countries. There's also work relevant for campaigns. So there's a multi-country review of yellow fever PMVC reports to identify ways to improve campaign quality. And that will surely feed into, I think, the guidelines for campaigns which are under development from the WHO. So WHO leading the work to develop campaign guidance. So that's it from me. I'm happy to take questions.
Thank you, Alex, and you will have questions. But before that, I have a tricky question for Hans. Are you ready for this? And it's something that's on our mind too, you know, we at Measles Rubella Initiative. So here it goes. How is COVID-19 vaccine manufacturing impacting the yellow fever vaccine manufacturing volume? We are also hearing a lot in the news, etc., about the impact of the global supply chains. Are these challenges causing any issues for yellow fever vaccine manufacture? Over to you, Hans.
Thank you. Just making sure that you hear me well.
Yes.
Good. We've had some impact reported by our yellow fever manufacturers, but we have been very fortunate. It has been very limited, and the impacts that have been reported and which has translated into reductions in availability. We've been able to, you could say, mix and match, get more from alternative suppliers, or postpone a delivery or two where the stock situation in country would allow, and there was a sufficient stock level to do so. So really, in terms of supply availability, we've had less than 3% impact during the pandemic. So really, next to nothing. In terms of the overall supply chain and the impact, we have, as many of you know, due to the much reduced travel, international travel that we see, across the globe. The availability of air cargo capacity, which we use on commercial flights to transport vaccines from suppliers to countries, have been quite severely impacted. It started out reducing the cargo capacity tremendously during the first months of the pandemic last year. Since we have been much better in finding, together with our freight forwarders, in finding transport solutions. We have done various combined charters to hard to reach destination where really commercial flights were not operating. That was still in the early days of the pandemic. Since then, and during most of 2021, and for most destinations for yellow fever vaccines, we haven't been that severely impacted, and have been able to find the transport solutions that were needed. We have seen some delays in primarily the booking of flights, but because of the reduced availability, but overall it's been relatively, the impact haven't been severely impacting supply to countries during 2021. So we are starting to get out of the woods, especially for yellow fever vaccine supply. Over.
Thank you so much. I know you're making it sound simple, but it's not. Thank you very much for your work. I would like to take this little moment to thank our interpreters who have been with us since we started. Thank you very much. They're taking leave, so we'll have to continue in English, and I hope it's not a problem. You can raise your hand if you have any questions. We are here. So once again, thank you very much to the interpreters, but please continue. And we do have another question linked to what you said, Hans. We have a question for you here. Just a moment. Could you describe in a little more detail how the DSWG is able to use the expression of country readiness or commitment?
Absolutely. We are seeing that a number of countries are yet to start their preventive mass vaccination campaign. And countries like Uganda, Ethiopia, and the other countries that are still to implement will, through expression of their demand, will enable us and partners communicating clearly and accurately the projected demand to our dear suppliers. This demand expression will enable suppliers' decisions. Some suppliers are making decisions around allocation of their production facilities. They are making that on a regular basis, but particularly during this time of competing priorities with COVID vaccine production. It's really important that we are clear and accurate in our communication to manufacturers on what is needed. If we fail in that endeavor, we increase the risk that manufacturers will make decisions that are adversary, not conducive to the objectives of the I strategy. I don't think that risk is increasing, but the better we are at projecting accurately what is needed and when, the better job we do of mitigating that risk. So indeed, accurate forecasting planning, communicating plans to partners in country and globally is really important to ensure that we have suppliers' commitment and the availability that's needed to facilitate the activities in country.
My apologies. I was talking with the mute button on. We have a hands up from Dr. Turner from Nigeria. Dr. Turner, would you like to come in?
Okay, thanks a lot, Priyanka. And just a few comments that I wanted to make. Thanks a lot to Hans and Alex. So my comments will be around the information shared by Alex. And we clearly see the struggle around the yellow fever introduction into either the second year of life or the opportunities that that brings alongside. Because this is something that from the Nigeria program, there have been challenges around that. Just to know how much engagement are we having around the NITAGs or the regional technical advisory committees around pushing countries to either include yellow fever into the second year of life routinely or encourage them to have these opportunities for that. I think it will be interesting to note so. The second will be some of the charts and the trends you had shown around measles and MCV1 as well as yellow fever. Clearly also shows maybe some stagnation. I had shared from the Nigeria presentation the WINIC estimates, and you will notice for Nigeria that over the last 4 years, the yellow fever estimate has been at 54%. This is clearly so because the estimates of yellow fever are drawn from the MCV1 coverages. Most coverage surveys do not have yellow fever coverage as part of it, so they extrapolate yellow fever coverages from MCV1. What do we need to do to ensure that huge surveys like the DHS or surveys include yellow fever antigen as one of the outputs so that we're sure we're actually getting the true yellow fever coverages versus drawing this from the MCV1 coverage. So I think those are the two things that I wanted to highlight on, and it'll be great to hear your response around this. Thank you.
Thank you, Dr. Tan.
Thanks, Turner. Nice to see you here. Sorry that we're not together in person. Yeah, I mean, I think that the experiences from Nigeria are really rich and really important in terms of the the challenges and ways you've managed to overcome challenges for integration of YF into the 2IL platform. I remember we had this discussion in Brasilia about this specific issue. I mean, I think any lessons learned from the national experience and also subnational experiences, because I from memory there were different approaches taken in different parts of the country, but could be very useful for other settings. I agree. I think that the NITAGs are the perfect forum for advocating for this. I think that this is definitely one of the approaches, as well as also through regional forums and the RITAG. So yeah, couldn't agree more. And I think that this is the approach, at least from the headquarters side, and I imagine with Afro colleagues that we take in terms of the advocacy. In terms of the issue around the surveys and the use of measles as a proxy for generating estimates of yellow fever coverage, this is certainly an issue, and I think really that's going to play out differently in different settings depending on again the gap that we've seen presented, and it's different in different years. And so I think the only way really is to try and get yellow fever integrated into all of the probability-based survey tools. So yeah, I think this has been raised with the data team, and certainly is something again to take back and ensure that this is the approach moving forward. Over.
Thank you, Alex. And staying with Nigeria, we have a question from William in CDC. What strategies are in place to address access to yellow fever vaccine requirements during outbreaks for reactive vaccination campaigns?
Is that for Hans or for me?
I think more for you. What strategies are in place to address excess? Okay, more for Hans, yes.
Sorry, Priyanka, would you be able to repeat the question?
Sure. You can also find it in your Q&A. This is a question from William. What strategies are in place to address access to yellow fever requirements during outbreaks for reactive vaccination campaigns?
Could you clarify excess of what? It's not clear to me.
Vaccines, yes.
If William is still online, perhaps William can repeat the question. William Komakesh, are you still on? Yes, I can see you online. Would you like to ask your question to Hans?
Yes.
Yeah. Once more, thank you. Yeah, this question, I'm raising it because in one or two occasions, we've had issues of getting access to vaccines for yellow fever outbreak vaccination. At one point, it may be delayed, and at the other time, we may get it timely. So in the presentation so far, not much have been said about access of the yellow fever vaccines for outbreaks. So my question now is, what are the strategies to improve both access in terms of availability of the vaccines and at the same time, access in time of timely response so that we get this and use it as at when required? I don't know if it is clear now.
Oh, it is. Thank you so much, William. Very clear. So let me start maybe with a little bit of background. We have contracts in place and will continue to have contracts in place with two manufacturers for the emergency stockpile. Together, they keep available 6 million doses for outbreak response. And we have, since 2016, not been a situation for yellow fever vaccine where we've been close to depleting the stockpile. We have, together with the suppliers and their tremendous effort, been able to have 6 million doses available for outbreak response at all times. So from a supply perspective, since the last 5 years, actually around this time, 5 years ago, the outbreaks were declared over. We've not been in a situation where we've not had enough availability. And I must also say that for yellow fever vaccine, like for any other ICT stockpile, our suppliers are tremendously fast and responsive in making the doses available when a request comes through. I don't know if we do have representatives from the ICT or the ICT Secretariat here, but in terms of the response, we have a commitment for supply of yellow fever within 10 working days since the receipt of an ICT request from a country. So the ICT obviously needs some days to deliberate, and we then have around 7 days to work with our suppliers and freight forwarders and carriers to make sure that the delivery is in country. And for yellow fever, this commitment of 10 working days is most often accomplished. The specific situation that you refer to, William, I'm not knowledgeable to go into those examples of potential delays in supply. And other than to say that for Nigeria, connectivity, the flight availability, the capacity is quite good. So most often we would be able to supply within the 10-day deadline that we've given ourselves in the ICT partnership. But as I said, I don't know if there are representatives from the ICT that may be able to better describe or give you a particular response to the incidents you are referring to. Over.
Thank you. And we are also opening the floor for any last few words, any last few questions before we wrap up. Would anybody like to come in? All right, it seems that Hans got the last word. Thank you very much. Before we close, I would like to once again thank all our speakers, interpreters, and all the behind the screen magicians who have made it possible today, and also especially the over 140 participants that we clocked today. We are looking forward to seeing you again tomorrow, where I'll hand over the mantle of emceeing of this event to Shagun Kher, who is a communication officer for the World Health Organization. We hope you enjoy your second day with us and see you tomorrow. Thank you.
Thanks, everyone. Thanks, Priyanka.
Thank you. Thank you, Rocky.
Thanks, everyone.
Thank you.